in new grade 2 disability cases from 5851 in 1516 to 2761 in 2019-20. Ladies and gentlemen, as you're aware, today is Gandhiji's Martyrdom Day, and it's not a coincidence that we celebrate National Leprosy Day on the day that we have chosen, that is today, because as we are aware, Gandhiji worked tirelessly for uplifting the marginalized and those who were suffering with disabilities or handicaps like this, like those afflicted with leprosy. He worked tirelessly throughout his political and social life that he led in working towards raising the awareness around these subjects. And it'll be a humble homage to him if we continue and rededicate in our efforts to this removal of this scourge from this country. I take this opportunity to congratulate the program and all the contributors for their efforts in developing these the interventions that we are going to launch today through our Honorable MOS, who has consented to be here despite her very busy schedule. And the National Anti-Leprosy theme for 2023 is Let's Fight Leprosy and Make Leprosy History. This will surely help raise community awareness regarding leprosy disease, prevention, treatment, stigma, and discrimination. Along with the support of all our development partners, community bodies, and the participation from the people who have come out of the scourge and who are still suffering, these initiatives will be better implemented, and India will surely be able to achieve zero transition of leprosy in 2027. On this National Anti-Leprosy Day, let's pledge to fight leprosy and make leprosy history. Jai Hind.
Thank you, ma'am. Ms. Roli Singh Ji, Additional Secretary and Mission Director, National Health Mission, for your remarks. And now, ladies and gentlemen, for the address, may I invite respected Professor Dr. Atul Goyal Ji, Director General of Health Services, Ministry of Health and Family Welfare, Government of India. Please, sir.
A very good morning to all of you. Honorable Minister of State for Health, Dr. Bharti Praveen Pawar, my colleagues from the Ministry, my colleagues from the Directorate, and my colleagues from across the country and the WHO. Well, I'll just keep it very brief to few technical points which need a mention, and they should also raise a word of caution. You see, leprosy is a difficult disease. It's not an easy disease like tuberculosis. It's a difficult disease to eradicate. And eradication is not just in terms of numbers. When I talk to skin specialists across the country today, leprosy has changed in its clinical presentation. So detection of new cases would be difficult in times to come. It will not be easy. And we will have to think as to how we would detect these cases and actually diagnose them also, because here the roles of so-called slit smears may be limited. Then the second thing is that it worries me that leprosy, like any other tropical disease, which Mr. Rajiv Maji said, neglected. I think we should stop using the word neglected. For us, these tropical diseases are important. So they should be called important tropical diseases. The problem with these diseases are they are non-glamorous. Now, for example, today, people who take up skin, take it up for the reason of cosmetology. It's one of the highest, the branches which is taken up very easily by people. It goes very high in the list of choice, but they take it up for cosmetology. They don't take it up for the sake that they are going to detect and treat leprosy. So that is what worries me across the country. So is it that skin specialists have totally lost interest in leprosy? Yes, to an extent it's true. So this is extremely worrying. And the third thing is that as the disease changes its nature, its treatment will also become difficult. Because as we know, the drugs act against leprosy and tuberculosis only when the lepra bacilli are growing. But in diseases which have atypical presentation, these bacilli may not be growing at a very rapid rate. So determining as to how and for how much time the drug treatment would be required in future is a question that would require answers. So with these few small cautionary notes, I would still wish the program a success, and I hope we are able to eliminate leprosy as we think. Thank you.
Thank you, Professor Dr. Atul Goyal Ji, Director General of Health Services, for your address. And ladies and gentlemen, may I now request respected Shri S. Gopalakrishnan ji, Special Secretary, Health and Family Welfare, Ministry of Health and Family Welfare, Government of India, to kindly grace us with his few words. Thank you. Please, sir.
माननीय स्वास्थ्य राज्य मंत्री जी, colleagues from the health ministry, all related agencies, development partners, etc. मतलब the history of where we have got here has been explained by Rodrigo and Atul Goyal Saab. The technical aspects have also been highlighted by the DGHS sir. I would only like to add one point कि जहाँ तक हम पहुँचे हैं, possibly in retrospect it will sound as the easier part क्योंकि अभी numbers कम हैं और दुनिया भर में it is becoming less of a priority, less neglected, etc. But this last mile जो है 27 तक elimination, I personally feel is going to be more tougher than what has been achieved so far. But the positive side is we have the experience, we have a whole lot of stakeholders working. This elimination will not happen without the best involvement of all the state governments and the state machineries, the development partners and everybody else related in the health. And unlike the past many decades back, etc., Ajkal we have the best technologies also. So towards that direction, with the strong leadership provided in the ministry today and the overall all of government approach, we are going to have a strategy and a portal which will help us take there. So I think that is the significance of today's event, कि we are now having a clear strategy किसको क्या कैसे करना है, which will help us achieve. So I wish to congratulate all the stakeholders and sound out that this is a very good opportunity. We have the wherewithal, we have the technology, we can do it. So I'm sure there is no way we will not end up doing, but it involves the dedication of all the stakeholders, and I'm sure we will be able to achieve the within 2027 as is foreseen. So with these few words, I commend the program and look forward to its effective implementation. Thank you.
Thank you, Shri S. Gopalakrishnan ji, Special Secretary, Health and Family Welfare, for your address. And may I now humbly request Honorable Minister of State for Health and Family Welfare, Dr. Bharti Praveen Pawar ma'am, to kindly release the plan document, that is the National Strategic Plan and Roadmap for Leprosy for 5 years, that is 2023 to 2027. So this is the National Strategic Plan and Roadmap for Leprosy, 2023 to 2027. Yeah, I'll request Anil sir to kindly join us on stage. Rajiv Manji ji, please come onto the dais. And also Mandal sir is here with us. I'll now request Honorable Minister ma'am to kindly release the national guidelines for surveillance. And now Honorable Minister ma'am will release the national guidelines for surveillance of antimicrobial resistance in leprosy. May I now request Honorable Minister ma'am to please launch the awareness video.
इन हाथों ने बहुतों को सजाया है। लोग कहते थे कि जादू है इन हाथों में। फिर एक दिन ये हाथ रुक सा गया, मानो मेरी जिंदगी ही रुक गई। पर गलती मेरी भी थी। वहां पर मुझे एक धब्बा नजर आया। पहले हमने ध्यान ही नहीं दिया, बस उसको छुपाने लगा, पर उंगलियों में कमजोरी सी आने लगी। तब हम डॉक्टर के पास गए।
ये छुपाने वाली बात नहीं, ये डॉक्टर को दिखाने वाली बात है। शरीर पर सुन्न दाग पाए तो डॉक्टर को जरूर दिखाएं। ये कुष्ठ के लक्षण हो सकते हैं, लेकिन घबराइए नहीं, कुष्ठ का पूरा इलाज हो जाता है। खुद का निरीक्षण करें, लक्षण पहचानें और कुष्ठ मिटाएं।
आज मेरे हाथ फिर से लोगों को सजाने में लगे।
So that was the awareness video, and this video will be shown nationwide for awareness. And I will now request Honorable Minister Ma'am to kindly launch the revamped Nikusht 2.0. Thank you so much, Honorable Minister Ma'am. Ladies and gentlemen, may I now have the privilege of inviting Honorable Minister of State for Health and Family Welfare, Government of India, Dr. Bharti Praveen Pawar ji, and request Honorable Minister Ma'am to kindly enlighten us with her kind words. Please, ma'am.
नमस्कार, श्री गोपाल कृष्णन जी, प्रोफेसर अतुल गोयल जी, मिस्टर रोली सिंह जी, डॉक्टर Rodrigo Offering, and all the experts and participants of the event who have assembled here for the observation of National Anti-Leprosy Day. It's my privilege and opportunity to share my thoughts with everyone and for the betterment of leprosy patients in the country. Before I start my heartfelt tribute on the occasion, the death anniversary of our father of nation, Mahatma Gandhi ji, which is also celebrated as Martyrs' Day to commemorate freedom fighters who sacrificed their lives to get us freedom. Friends, the concern and commitment to treat leprosy have its origin in our history. Mahatma Gandhi ji had an enduring concern for people affected with leprosy. His vision was not only to treat them, but also to mainstream them in our society. Our efforts to eliminate leprosy from this country under the National Leprosy Eradication Program is a great tribute to his vision. We are successful in achieving the prevalence rate, 1 case per 10,000 population at national level in 2005. But the need of our is consistent efforts to eliminate it. We all know that leprosy is a curable disease. But if not detected and treated at the early stage, during my medical practice, I have seen how it can cause permanent disabilities and deformities among the affected person, and which often lead to discrimination of such persons and their family members in the community. This is a matter of concern for me that our country has nearly 52% of the total cases of leprosy worldwide. But we have firm resolve to fight the disease through different interventions of National Leprosy Eradication Program, NLEP, with the wholehearted support and active involvement of our common citizens and the society at large. Our leprosy program of the country strives to detect and treat cases as early as possible, gives treatment free of cost to prevent the development of disabilities and deformities and medical rehabilitation of those with existing deformities. I am delighted to mention that recently we have revised the welfare allowances of rupees 8,000 to rupees 12,000 to the patients who undergo for the reconstructive surgery. The program also works towards spreading awareness and reducing stigma attached with the disease. Friends, under the visionary leadership of our Honorable Prime Minister Shri Narendra Modi ji, we have adopted comprehensive measures for prevention of development of disease. And from the year 2016, renewed efforts were made for actively detecting cases under the Leprosy Case Detection Campaign, LCDC. Surveillance was also strengthened by introducing ASHA-based surveillance for leprosy suspects, whereby grassroots level workers constantly engaged in examination and reporting of suspects. Special emphasis under the Focus Leprosy Campaign, FLC, was given to areas that were difficult to access or had child cases and cases with disabilities. Friends, since 2015, with the constant efforts under NLEP, we are able to prevent many number of disability due to leprosy. India is making progress and the number of new cases are declining year after year. The prevalence rate of leprosy has come down from 0.69 per 10,000 population in 2014-15 to 0.45 in 2021-22. Further, annual new case detection rate per 1 lakh population has come down from 9.73 to 5.52. 9.73 in 2014-15 and 5.52 in 21-22. Ladies and gentlemen, we all are aware that there is so much stigma that surrounds leprosy. It starts them on a difficult journey of telling family members and the community and their community. They know that each time they tell someone, they have fear of stigma and rejection. Hence, to address the challenges of any existing stigma and discrimination on account of the leprosy, a nationwide campaign called SPARSH, Leprosy Awareness Campaign, SLAC, was introduced on the occasion of Anti-Leprosy Day in 2017. Our government is full-heartedly committed for welfare of our leprosy patients. Our ministry has taken a decision to achieve a Sustainable Development Goal 3.3 for leprosy 3 years before, by 2027, in state goal, global goal of 2030. Friends, our ministry, under the able guidance of our Honorable Health Minister Dr. Mansukh Mandaviya ji, has developed 2 guidelines. First is the National Strategic Plan and Roadmap, which will surely motivate and help the officials under NLEP to work more holistically and will streamline the ways to achieve the interruption of transmission by 2027. Another one is National Guidelines for AMR, antimicrobial resistance, which will provide the guidance on setting a surveillance mechanism for resistance cases and will clearly define management protocol. Today I am delighted to release this roadmap and the guidelines along with awareness videos and Nikush 2.0. I am sure that such newer initiatives under this program will ultimately take us towards achieving leprosy-free India. Friends, with the goal of achieving universal health coverage in India, we embarked on a journey to provide security to poor and vulnerable populations of the country from excess financial expenses arising out of medical emergencies. In a quest to serve the last mile as always mission of our Honorable Prime Minister, Ayushman Bharat Pradhan Mantri Jan Arogya Yojana has achieved several milestones and made possible for millions of people to avail quality healthcare services without worrying about the financial implications on their lives. To strengthen this, we also launched Ayushman Bharat Digital Mission, ABDM, on 27th September 2021, nationwide with the aim of developing the necessary backbone to support the integrated digital health infrastructure of the country. Ladies and gentlemen, I hope your deliberations during your day-long panel discussions on leprosy program will lead concrete and innovative outcomes. My best wishes for the same. Friends, on the occasion of National Anti-Leprosy Day 2023, let us take pledge today that we will fight together to achieve leprosy-free India by 2027. Let us fight leprosy and make leprosy a history. Dhanyavad. Thank you so much. Jai Hind.
Thank you, Honorable Minister Ma'am, for your pertinent address. And we are deeply grateful that you spared some time for us and graced the occasion. So, ladies and gentlemen, our Honorable Minister of State for Health and Family Welfare, Government of India, Dr. Bharti Praveen Pawar ji. Shall we continue? Yeah. Next, ma'am, we have a message by our Honorable Minister, sir. Yeah, right. Thank you, ma'am. So now, ladies and gentlemen, we have a video message by Honorable Union Minister, Ministry of Health and Family Welfare, Ministry of Chemicals and Fertilizers, Government of India, Dr. Mansukh Manviya ji. Can we have
नमस्कार। स्वस्थ भारत, समृद्ध भारत के सपनों को साकार करने के लिए स्वास्थ्य मंत्रालय हमेशा प्रयासरत रहा है। राष्ट्रपिता महात्मा गांधी के जीवन से प्रेरित आज हम कुष्ठ रोग मुक्त भारत बनाने की परिकल्पना को साकार करने के लिए एकत्रित हुए हैं। महात्मा गांधी ने अपना संपूर्ण जीवन कुष्ठ रोगियों को पुनर्वासित कर समाज की मुख्यधारा का हिस्सा बनाने में समर्पित कर दिया। गांधी जी के इस योगदान को हम विफल नहीं होने देंगे। आज हमारा देश उन बीमारियों से लड़ रहा है जिससे हम अपना बचाव और उपचार करवा कर पूरी तरह हेल्दी रह सकते हैं। आवश्यकता है थोड़ी सी सावधानी की, समय रहते लक्षणों की पहचान और इसका जल्द से जल्द उपचार। आज के इस पावन दिन पर हमें कुष्ठ रोगों से जुड़ी सभी भ्रांतियों और सामाजिक भेदभाव से मिलकर लड़ने के लिए संकल्प लेना है। भारत ने कोविड प्रबंधन और टीकाकरण के लिए विश्व को एक आदर्श प्रदान किया है। जहां विश्व भर में लोगों ने सरकारों द्वारा लगाए गए प्रतिबंधों का विरोध किया, वहीं भारत ने नरेंद्र मोदी जी के नेतृत्व में 140 करोड़ लोगों द्वारा कोविड दिशा निर्देशों और नियमों का उत्साहपूर्वक पालन किया गया। भारत ने गुणवत्तापूर्ण टीके बनाए जिनकी प्रभावोत्पादकता पूरी दुनिया में साबित हुई है। भारत ने जो भी ठाना है वह करके भी दिखाया है। अभी हाल ही में माननीय राष्ट्रपति महोदया जी ने प्रधानमंत्री टीबी मुक्त भारत अभियान को लॉन्च कर समाज के हर वर्ग के व्यक्तियों को सहयोग देने के लिए आह्वान किया। इस तरह का सहयोग, सिनर्जी और सहभागिता कुष्ठ रोग मुक्त भारत बनाने में भी हमें करनी होगी। हाल ही में भारत ने स्वस्थ ढांचे की सुदृढ़ीकरण में एक उल्लेखनीय और महत्वपूर्ण उपलब्धि प्राप्त की है। देश में 1,54,000 आयुष्मान भारत हेल्थ एंड वेलनेस सेंटर संचालित हो गए हैं। प्रधानमंत्री श्री मोदी जी की सोच को साकार करने के लिए राज्यों और केंद्र शासित प्रदेशों और केंद्र सरकार की एकजुट व सहयोगात्मक प्रयासों ने भारत को विश्वसनीय, व्यापक प्राथमिक स्वास्थ्य देखभाल सेवाओं के लिए एक वैश्विक आदर्श में रूपांतरित कर दिया है। पूरे देश में ये केंद्र नागरिकों तक प्राथमिक स्वास्थ्य सुविधाओं को सुगमता से पहुंचाने और उनका अधिकतम लाभ उपलब्ध कराने में हमें सहायता कर रहा है। भविष्य में सार्वभौमिक स्वास्थ्य के लक्ष्यों को हासिल करने में इनकी भूमिका बहुत ही महत्वपूर्ण होनी है। भारत के स्वास्थ्य क्षेत्र में पिछले 8 वर्षों में बहुत सारे मुकाम हासिल किए हैं। जहां 2014 में जहां केवल 6 एम्स थे, वर्तमान में 22 एम्स है, जो देशवासियों को टर्शरी हेल्थ केयर सेवा उपलब्ध करा रहा है या शीघ्र ही उपलब्ध कराने की श्रेणी में आ रहे हैं। भारत का सपना है कुष्ठ रोग मुक्त भारत और संयुक्त राष्ट्र का सतत विकास के 3.3 लक्ष्य को प्राप्त करने के लिए 2 दिशा निर्देश, राष्ट्रीय रणनीतिक योजना और रोडमैप, एंटी माइक्रोबियल प्रतिरोध निगरानी और ऑनलाइन पोर्टल निकुष्ठ 2.0 इस अवसर पर लॉन्च किए गए। स्वास्थ्य और परिवार कल्याण मंत्रालय ने यूनाइटेड नेशंस सतत विकास के 3.3 लक्ष्य को 2030 से घटाकर 2027 कर दिया है। हमें विश्वास है कि अपने सभी प्रयासों से हम निश्चित रूप से लक्ष्य को प्राप्त करेंगे और भारत को कुष्ठ रोग मुक्त बनाएंगे। भारत सरकार के स्वस्थ भारत, समृद्ध भारत और नए भारत की आधारशिला को सुदृढ़ बनाने का समय आज आ गया है और हमें पूर्ण विश्वास है कि अगर हम सभी मिलकर एक लक्ष्य, एक कर्तव्य, स्वस्थ राष्ट्र का निर्माण कर सकते हैं। आइए हम सभी मिलकर कुष्ठ रोग मुक्त भारत बनाए। जय हिंद।
बहुत बहुत धन्यवाद माननीय स्वास्थ्य एवं परिवार कल्याण मंत्री भारत सरकार डॉक्टर मनसुख मांडविया जी, आपके उद्बोधन के लिए, आपके प्रेरणादायक शब्दों के लिए। And now for word of thanks, I would request Deputy Director General Leprosy, respected Dr. Sudarshan Mandal ji.
Good morning, everyone. Honorable Union Minister of Health and Family Welfare and Union Minister of Chemical and Fertilizer, Dr. Mansukh Mandaviya ji. Honorable Minister of State, Dr. Bharati Praveen Pawar. Respected Sri S. Gopal Krishnan Sir, Special Secretary Health. Professor Atul Goyal Sir, Director General Health Services. Madam Roli Singh, Additional Secretary and MD NHM, Dr. Anil Kumar, Additional DGHS, Dr. Rodrigo H. Afrin, WHO Representative to India, Sri Rajiv Majhi, Joint Secretary, Leprosy, and all the invited dignitaries, distinguished guests and colleagues. I consider it a great privilege to propose a vote of thanks to all who have made it convenient to attend this important event of observation of Anti-Leprosy Day on 30th January, this day in India. I, on behalf of Ministry of Health and Family Welfare and the National Leprosy Eradication Program, and also on my behalf, extend very hearty vote of thanks to everybody who have gathered here, who have assembled here, in spite of their busy schedules. You know that today is the death anniversary of our father of nation, Sri Gandhi ji.
who was, the strong advocate for the rights and dignity of the people affected by leprosy. He believed that people with leprosy should not be shunned and discriminated against, but rather should be treated with respect, love, and dignity. His legacy continues to inspire the organization and individuals around the world who are working to improve the lives of the people affected by leprosy. You know that National Leprosy Eradication Program is working towards zero transmission of leprosy by 2027. The major challenge to this goal of zero transmission of leprosy by 2027 is to detect leprosy early, early detection of leprosy, and providing suitable care and support to the leprosy affected people. But you know that we have achieved the goal of, elimination of leprosy in 2005 to the level of less than 1 per 10,000 at the national level. So, today's theme also selected, that let's fight leprosy and make leprosy a history. And that has been a fitting tribute to the stalwart who had genuine concern for the poor and vulnerable section of the country. We are deeply grateful to the Union Minister of Health and Family Welfare and Chemical and Fertilizer, Dr. Mansukh Mandaviya ji, for enlightening us and addressing us through a video message. His address was unique, as always, because of novelty of ideas, as also his unique style. Sir, I thank you for giving us keynote address today. I take this opportunity to express my sincere thanks to Honorable Minister of State Dr. Bharti Pravin Pawar ji for her meaningful address. We are extremely grateful to you, Madam, for sharing such knowledge and insights on the topic of leprosy in the country. And also you have spoken about the challenges that we are facing, that the leprosy patients are facing in the country. I would also like to express my deepest gratitude to Sri S. Gopalakrishnan, sir, Special Secretary Health, for have taken time out from his busy schedule to attend this event and provide his valuable guidance. I would also like to thank Professor Atul Goyal, sir, DGHS of the Ministry, for providing continuous supervision to us in all the activities, and also to always ensure that we always do the right thing in the right way. I would like to thank also Madam Roli Singh, Additional Secretary and Mission Director NHM, for sharing her views with us on a topic of such contemporary relevance. I also express my sincere thanks to Dr. Rodrigo H. Offrin, WHO representative to India, for an insight to the global and Indian scenario of leprosy. I would like to express my profound thanks to Dr. Anil Kumar, additional DGHS, who has been working for eradication of leprosy in the country since long, and also he was instrumental and also provided us the path to prepare the two guidelines. Already those have been released today. The one is that National Strategic Plan and Roadmap for Leprosy 2023-27, and also National Guidelines for Antimicrobial Resistance for Leprosy. So we are wholeheartedly thankful to you, sir. I also express my sincere thanks to Sri Rajiv Maji, Joint Secretary Leprosy, for overseeing the implementation of government policies and programs in the country related to leprosy. Many thanks to all the invited senior dignitaries, officers, colleagues, private stakeholders, members from the NGOs for their presence and active participations. Lastly, I must thank my Central Leprosy Division and National NCD Division team, and also the WHO team, who have worked with great dedication and sincerity to make this program a grand success. Thank you very much.
Yeah, thank you so much, ladies and gentlemen. Please rise for the national anthem. Thank you.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उज्जल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
Ji, sure, sir, ji. So now, ladies and gentlemen, we'll observe 2-minute silence on Martyrs' Day in memory of those who sacrificed their lives in the struggle for India's freedom. Thank you so much, ladies and gentlemen. Kindly be seated. And we would like to thank our Honorable Minister Ma'am and other dignitaries on the days. And ladies and gentlemen, as you know, we have 3 more sessions after this, but we conclude our inaugural session with this. And now we'll have a tea break and we'll reassemble here at 11:30. So please do join us for the next session. Thank you so much for now. We are done for the first session. Ma'am, please come onto the dais. Shall we begin, sir, or wait for Mandal, sir? Shall we wait for sir to come? Okay, sure. Right, Jay, as you suggest, sir. So now we'll start with our first session. The National Leprosy Eradication Program, that is NLEP, is a program in India that aims to eliminate leprosy as a public health problem. The program is run by the Ministry of Health and Family Welfare, Government of India, and is implemented through a network of health facilities at the national, state and district levels. And now Dr. Sudarshan Mandal, Deputy Director General Leprosy, will give us an overview of NLEP and its recent achievement. So it's all over to you.
Hello everybody. My job is to apprise you regarding our program called National Leprosy Eradication Program. I will give an overview of that program, and also I think I will depict the recent achievements of that program in our country, India. So I think before going to the next slide, I think you know that this program, National Leprosy Eradication Program, was started as control program, National Leprosy Control Program in 1955, and there was a huge progress, you know, as we achieved that elimination target or elimination goal of the country in 2005, which is less than 1 per 10,000 population. And we achieved many things. I mean, so I will mention that after giving you an overview of our achievement also. So next slide, please. Yeah. So you know that already many speakers, I mean, who were on the dais, have spoken about the role of Gandhiji, our father of nation, towards the leprosy patient, leprosy affected patients, and also not only the leprosy patients but also the most vulnerable section of the society, the untouchables and other sections of the society. So he had a great role. I mean, he was a visionary leader. He understood, first that in the country like India, we have to do something for the leprosy patients. And he was the first person in the country who tried his best to destigmatize this disease in the country. He was successful, in his effort to destigmatize it. But you know that the deep-rooted myths, misconception, whatever there or even now in the minds of our countrymen could not be, removed or eradicated in a single day or by a single person. You know the story of Parsuro Shastri, who was Sanskrit Pandit during that time of Gandhiji, and who was actually outcasted from his family due to affection of this disease, leprosy. And ultimately, Gandhiji was the person who took, who had given shelter to Parsuro Shastri in his Gandhi ashram, Sevashram. Sevagram, ashram, and made one small cottage for him. And he used to nurse Parsuro Shastri on a daily basis in the morning and evening. So Parsuro Shastri actually he was suffering from grade 2 disability. So you know the grade 2 disability actually it causes more discrimination or humiliation from the society because of different myths and misconception. And after so many times, after so many years, now we can boldly say that leprosy is curable. You know the role of MTD for leprosy. Leprosy is curable, and treatment is freely available in all the government health facility, and there is no shortage of supply. Our supply chain management is a robust one. Treatment of leprosy is free for everybody. Across the caste and creeds of the society. Next slide, please. This is the classification of leprosy. From our program, NLEP, we usually classify leprosy into two, possibacillary and multibacillary, and there is treatment. The duration of treatment for possibacillary is 6 months and multibacillary 12 months. And also, you know, the different kind of regimen. 2 drugs for possibacillary and 3 drugs for multibacillary. But most important thing is that we could not introduce lab testing for leprosy patients so far. It is done. I know that it is done at the mostly at the district hospitals and other apex hospital, not at the peripheral level. The primary health center or community health center. Lab testing. So we depend on clinical diagnosis of leprosy, depending upon the signs and symptoms, and there are 2 clinical signs for leprosy and 1 lab investigations. You know that slit skin smear is for leprosy patient is there only for the difficult cases. Only maybe 1% of the total new cases of the country we are performing that type of slit skin smear. But mostly we are doing clinical diagnosis through signs and symptoms of the leprosy patient, mostly signs. So if there is skin lesions, hypopigmented patches or reddish patch in the body, it depends on the number also. If you want to classify the disease into 2, if it is 1 to 5 lesions, then stamped as possibacillary. If it is more than 5, then multibacillary. If there is no thickened nerve or single thickened nerve, it is possibacillary. It is if there is more than 1, 2 or more thickened nerve in the body, mostly peripheral nerves, then you can classify it as multibacillary. Next slide. Can I get the physical copy of that? Hello. Can I get the physical copy of that presentation PPT? I think because I can't see the slide and it's very difficult to remember everything what is written there in the slides. Because there is no laptop arrangement here, and also I don't have that physical copy of the presentation. It is very difficult. I can probably my power of I has been increased. I could not see anything in the slides. I need some help. नहीं मोबाइल में क्यों मैं back side okay, then I will turn I have to turn my face towards that. Oh, no problem. नहीं प्रिंट आउट है मेरा, वो फोल्डर भी मंगा है, कहाँ है वो अभी लाता है? नहीं मैंने इसको बोला था संजीत को लाओ उसको. So I can see the so I have to see that backside screen. So that is the classification actually, and you know already I have spoken about that. I don't want to go into details about the treatment of leprosy. Everybody knows it, and at least the person who are sitting in front of me, everybody knows about what is the treatment of leprosy. So can I get the next slide, please? Yeah. So what is our SDG goal? SDG goal that is 3.3, and for non-communicable disease it is 3.4. There are altogether 17 SDG goal for the country. Yeah. Hello. So there are altogether 17 SDG goal for the country, for the world actually, all the member countries of United Nations, and leprosy is included in the SDG 3.3 as one of the 17 diseases of neglected tropical disease. I have put a query mark regarding neglected. I mean, they have mentioned that these diseases, 17 diseases, including including leprosy, kalajor, and rabies also is there, and so many diseases. I don't want to name all the diseases. So they are called neglected tropical disease. But you know that we have to change the name of the those group of diseases. These diseases are not neglected in our country, in other country also, other tropical country also. So we have to change the name of these neglected tropical diseases into focused tropical diseases. Instead of neglected, we will put the word focused there. So I mean that would be taken into file. I mean that is in process. We will change the name of neglected tropical diseases to focused, because we are, I mean, leprosy, rabies, and other diseases, other 17, they are not neglected in our country. So because they are not neglected in our country, we have to change the name of the group of diseases to focused I mean tropical diseases. So what is our goal? Our goal is that I will show in the next slide. Next slide, please. Yeah. So before that, let me speak about that 4 strategic pillars of global leprosy strategy 2021-2030. This is the global one, and we have prepared, and which has been released also today by the Honorable Minister of State, Dr. Bharti Pravin Pawar. That we have prepared one strategic plan that is called National Strategic Plan and Roadmap for Leprosy 2023-20. I mean, it's a 5-year plan. 2023-27, 5 years plan, and the global plan is you can see here 2021-2030. So the pillar, we kept all the pillars in our document also, in our national strategic plan also. The first one, the implement the integrated country-owned zero leprosy roadmaps in all endemic countries. I mean, that is the roadmap or NSP that we have released today. I mean, that was pending for a long time, but somehow, I mean, we could manage to release it today by our honorable ministers. And second one, scale up the leprosy prevention along with integrated active case detection. This is very, very important. You know that leprosy is a stigmatized and discriminated disease in our country, in almost all countries. And you know that leprosy still is prevalent in 130 countries in the world, but mostly it occurs in India, I think India, Brazil, and Indonesia, maybe Nepal, Bangladesh, and other countries also. So that is very important to detect the case. I mean, early case detection of any disease, not only leprosy, early case detection is very important to cut the chain of transmission of the disease. Particularly if we talk about the communicable disease, you have to cut the chain of transmission. So if you want to cut the chain of transmission, you have to give, you have to detect the case early and give treatment immediately. I mean, put the patient, leprosy patient, on treatment immediately after diagnosis. That is the main job. So that is one of the pillars. The second pillar. The third pillar is that, as because leprosy is a stigmatized and discriminated disease in the country, and still it is prevalent, still people think that leprosy may be due to past sins, or leprosy may be due to bad air, or leprosy may be due to curse of some higher caste people. So actually, after the discovery of the bacilli in 1872, that has been reduced. That stigma discrimination has been reduced, because everybody, I mean, the literate section of the country, they know that leprosy is due to a bacteria only, and it can be cured. And the patient and leprosy patients, after 3 weeks of treatment, cannot transmit infection to others. I mean, only the patient needs 3 weeks treatment only. Of course, whatever treatment regimen is there in our country, then after that the patient could not transmit infection to others. So that so in this way, stigma and discrimination has been reduced, but we have to bring zero stigma discrimination in the country, of course in the world also, by 2027 in our country, and maybe by 2030 in the world. And that fourth one, that manage leprosy and its complication, very important. I mean, it includes, it covers up everything. I mean, starting from the primary prevention, secondary prevention. Now I am talking about the tertiary prevention. Even some of the cases, go unnoticed, go undetected at early stage, and ultimately they suffer from grade 2 disability. And in many cases of grade 2 disability, you have to arrange reconstructive surgery for those patients. So the fourth point, I mean, you have to manage the complications. Not only, I am not talking about the grade 2 disability, but also other complications, like lepra 1, lepra 2 reactions, and so many complications. I mean, if you give drugs, medicine to any patients, there is always chance of having side effects of the drug and some reactions in the body, I mean, of the person who are taking those drugs. Next slide, please. So, yeah. So now they have arranged everything: the cordless mic, the laptop, and I will get the physical copy of the PPT also very soon, I think. So I will get everything from my consultant. So, the vision of NLP 2027, please remember the timeline. It is not 2030 now, because we have released the document NSP 2027 today. So now we have to reach the goal of zero transmission. There are 4 goals, or goals by 2027. First one is, the zero transmission, zero leprosy case in the country. Very difficult to bring that zero case of leprosy by 2007. So we have to work hard. I mean, I don't know in which way. Everything is laid down in the documents. But we have to work together. All the government officials, all the NGO people, all the development partners people, even the big partners, our WHO, we have to work together to bring that level of zero leprosy by 2027. The second one, of course, that zero transmission of leprosy infection. I mean, that's why I mentioned that you have to cut the chain of transmission. I mean, so that the index, the infection cannot, cannot be transmitted from the index case to the family members or contacts of the family and the other social members of the family. The third one is zero disability due to leprosy. I have discussed about it. And bringing zero disability almost, that will lessen actually the stigma and discrimination, because leprosy is stigmatized more because of its physical deformity, not only because of the disease itself, but because of its physical deformity. I mean, still I have seen so many differently able persons who actually get humiliated by our common citizens every now and there on the roads and in different places. I mean, because of their deformity. I mean, how can you tolerate that kind of that kind of humiliation or stigmatization or discrimination in the country for a patient who is also already suffering from? I mean, he cannot perform the the daily activities of activities of daily living, maybe personal activities of daily living, instrumental activities of daily living. He cannot perform because of that kind of disability in the legs or in the hands, even in the eyes. And last one, so last one is the zero stigma and discrimination. So this is about the milestones. I mean, it started in 1955 as control program. Then, of course, that was a big milestone for the program. In 1983, we renamed the program as eradication program, not control program. Directly from from control to eradication, not in between. There is no elimination. I mean, we tried at that. We thought at that time. I mean, our policymaker thought at that time that we have to have that eradication for the disease, not elimination of the disease. So in 1983, because MDT was introduced in 1982, then we included or introduced that MDT in our program in 1983. And at the end of 1983, the prevalence rate of leprosy was 57.8 per 10,000 population. And everybody knows that we achieved the elimination level of leprosy at the national level in 2005 to less than 1 per 10,000. I mean, from that 57.8 to less than 1 in 2005. And still there are some states in the country. I mean, we could not achieve the level at the state level or UT level because there are some states and UTs. If you consider the pre-COVID level, there are states like Chandigarh, Dadra Nagar Haveli, Bihar, Jharkhand, Odisha. I mean, I am talking about before 2020, before the COVID pandemic period. These are the states who could not achieve the state level elimination target, and still, if we consider the data of 2021-22, Chhattisgarh is the only state who could not achieve that elimination level at the state level. I mean, at the particularly for the state of Chhattisgarh. So, so the program remained little bit of static from 2005 to 2015 because that our vertical program and we had a very robust vertical program before 2005. So our government took a decision that we have to merge this vertical program with the general health system. So that was done in 2006. The vertical program of leprosy was merged with the general health system in 2006, and there was a period of and there was a static period from 2006 to 2015, and from 2015-16 we introduced so many new initiatives. I will show all those new initiatives in the later slides. And before that, we have to know what is the global picture, global scenario of leprosy, and what is the Indian scenario of leprosy. So it is given as far as the burden of annual new cases of leprosy, that is one of the indicator. For leprosy in the country, total number of new cases for a period of 1 year. We achieved a lot. I mean, the world has achieved also. We have also from that level of 244,000 cases of leprosy that has been reduced to, if you consider the data of 2020, 128. I mean, 128. Then in 2020-21, it was 140,000 cases of leprosy in the world, but India contributes major. I mean, it hovers around, always I speak about it, that it hovers around 50 to 60% of the total number of new cases in the world. Sometimes it's 57%, sometimes 58%, maybe 60%. But according to the last, annual report of leprosy in the country, we actually held 54% of the total new cases of in the leprosy. But if you compare the scenario of India and Brazil and Indonesia, the prevalence rate of India is less than the Brazil. Brazil prevalence rate is more than 1.05. As far as the latest data is concerned, but our prevalence rate has been reduced to 0.45 in the last financial year, and this year it is going round about 0.50. So because there are new cases are getting detected in the post-COVID period. And Indonesia, almost like India, the prevalence rate 0.45 per 10,000 population. So as far as the grade 2 disability is concerned, I mean percentage of grade 2 disability among the new cases, so India achieved a lot. That percentage of grade 2 disability among the new cases that has been reduced from 40% to 22%. Within a period of I think 5 years. So within a 5 years, the grade 2 disability, because we are now detecting new cases early, at the early stage, so they could not be converted to grade 2 disability. But in Brazil, the scenario is different. I mean, their grade 2 disability is getting increased day by day, year wise. If you consider the data of 2016, it was actually 13% of the total new cases, grade 2 disability, that has been increased to 21%, and Indonesia around about 9 to 10%. So this slide is very important. I mean, if you want to show the achievement, I mean, it's recent achievement. What is the this is the topic given to me, that what are the recent achievements of the program. So recent achievement I have spoken about. That prevalence rate was 57.8 per 10,000 population in 1983. That has been reduced to mere 0.45% now. So huge achievement for the program for India, and also that percentage of grade 2 disability. So it was almost 20%. It was almost 20%, and that has been reduced to last year it was 2.47% of the new cases, and now probably it is going around 2.3%. So now because and I have to apprise you all that first time at the national level we are observing this National Anti-Leprosy Day, and there are many reasons behind it. This slide shows one of the reasons. This is one of the reasons. I mean, we have to work hard. We have to work hard to bring down the zero transmission of leprosy by 2027, because that has been decided by our policymaker. You know that Niti Aayog. You have heard the name of Niti Aayog, and usually instruction flows to the office of Prime Minister to Niti Aayog, then from Niti Aayog to us, to the national program. So you know that there was a meeting under the chairmanship of Dr. V.K. Pal, member Health Niti Aayog, and in that meeting, I mean additional secretary, myself, and also joint secretary attended that meeting. And in that meeting, we have decided that we have to keep these 5 salient points to achieve the goal. These are the recommendations of Niti Aayog. The first one, you can understand that we have to bring zero stigma discrimination in the country. So that's why we need robust IECA campaign throughout the country. And we have decided today that campaign will be of full 365 days. I mean, it will end on 29th January next year, 2024. So we have started today. Previously, it was actually happened only for 14 days or maybe 1 month. But this year, we have started that IEC campaign, the mass campaign for leprosy in the country, and that will be going on throughout the year and to the 29th January of next year also. So it's a full year program. And everybody, we need help from everyone. I mean, who are not only sitting here, but all our stakeholders. Stakeholders mean everybody. I mean, not only the development partner, not only the WHO or others, but also the self-help groups, the Panchayat Raj institutions, the policymakers. Policymakers means the health minister of the state and UTs, the health secretary of the state and UTs, everybody, and DMs, the head, district head of the district heads of the country. So we have to involve everyone, and we have to involve also the line ministries. There are altogether we have selected 29 line ministries and department who would be involved. Already we have that document also. Who would be involved, because it cannot be done solely by the Ministry of Health and Family Welfare. We need support from the line ministries, and they agreed to support us so that we can achieve the target by 2027. And we have to involve the medical colleges also. 4 department I saw that we need support from the 4 departments of every medical college, all the government medical college, maybe some of the private medical colleges also, and of course the all 22 AIMS in the country. So I think I can skip this slide because our Honorable Minister of State, Dr. Bharti Pravin Pawar, has spoken about the new initiatives which we have started since 2015-16. It includes, that LCDC, the ABSULs, and the sports campaign, and so many things. Special plan for the difficult and tribal areas. And you can see that we have started that single dose rifampicin for the contacts of the index cases, and the saturation coverage of that single dose rifampicin is very good in the country, more than 70%, 80% like that. In some of the states it is in UTs it is more than 90%. So very good coverage of that single dose rifampicin to protect our contacts from the disease of leprosy, and it gives usually, according to the recent studies, it gives usually 60% protection. That is a good component, a good new initiative for our program. Then monitoring, supervision, and IC campaign I have spoken about. The convergence of leprosy screening under NHM. You know that we are running so many projects, program, and altogether more than 30 and more than that. Programs, national program are there. So we need a convergence of all the national programs towards our leprosy patients. There are so many social benefit program also, and so many things. We have to converge all those benefits, all those programs for the benefit of our diagnosed leprosy patients. Yeah, so this is the flow actually, how to, who will suspect the case, who will screen the cases. It is done at the level of ASA and ANM, then they usually refer the case to the medical officer of PSC, and that is the flow, everybody knows about it. And this is the comparison between the pre-COVID scenario and during the COVID scenario, because 2021 and 22, that is considered as one of the year. We suffered from that COVID pandemic for 2 years. 2 years. Now I got the physical copy also. So see, such a committed, dedicated consultant we have in our Central Leprosy Division. So if you compare the, all the national programs suffered due to COVID pandemic, not only leprosy program, but our TB program also and other programs also. That's why the new cases of leprosy that has been reduced from that 114,000 to mere 75,000. And in 2019, I think 2021 also, we had only 65,000 new cases, not even 75,000. So this is the data, and there is a reduction of the indicators also, except that grade 2 disability. That has been increased a little bit from the pre-COVID level to the post-COVID level. And these are some of the states, that where we started that LCDC, leprosy case detection campaign, and 15 states. And I think it is now going on in Nagaland. Dr. Sen, it is going on in Nagaland also. Yeah. So, and you can see the yield of the program. Yield of the campaign. That leprosy case decision campaign. 14,000 cases we could diagnose through that campaign only. and you see that total number of new cases. So in if you speak about that, I mean current scenario, current year scenario, I mean 2022-23. So we got the data up to November from the states and UTs. So according to that data, we diagnosed actually more than 72,000 cases, leprosy cases in the country, and out of which these 12 states actually they constitute about 57% of the total new cases till November 2022. And from you can imagine, I mean, you can see the yield from that leprosy campaign, 35% of the total new cases in this year 2022-23 up to November. Then these are the states we have to give special attention to. These 12 states. You can see the number states starting from that Arunachal Pradesh to Delhi also is included there, and so many eastern states. I mean West Bengal is there, Jharkhand, Odisha, Chhattisgarh. I mean all those states are, and you can see out of the total number of districts, how many districts they have actually more than that 1 per 10,000 prevalence rate. So altogether we have 82 districts in the country where prevalence rate is more than 1 per 10,000 in the country. So of course there was an achievement. If you consider the data of 2014-15, that has been the number of districts of prevalence rate, I mean more than 1 per 10,000, that has been reduced from that 136 to 82 according to the present last year data 2021-22. So I have talked about that involvement of all, not only medical colleges, but we have to involve our medical colleges, particularly government medical colleges. So what we did actually, we arranged one meeting with all the government medical colleges of the country under the chairmanship of Professor Atul Goyal, Director General Health Services. And so we had a good discussions with all the directors or principals, even the HODs of the 4 departments. You can see the 4 department with which we want to work, I mean for different kind of activities. So regarding, I mean after that meeting, they assured us they want to extend help or a support at least from that from those 4 departments: dermatology department, the community medicine department, of course, and physical medicine and rehabilitation department, and microbiology department. And you can see the list of activities we want to which we want to have from those departments for our leprosy program, I mean leprosy eradication program. So we have fixed our state leprosy officer of the states and UTs. They will coordinate with the medical colleges, concerned medical college of the state and UTs, to have to connect all those 4 departments of the government medical colleges first, and then then we can scale it up to private medical college also. So all kind of support we need to achieve the goal by 2027. And so these are the documents. Yeah, I have started late, so I will end late also. I need only 3-4 minutes. Who is the chair actually? I don't know who is the chair. So I need only 3-4 minutes to end my this presentation. So this is the heart of the matter. So I have kept only 3 slides for 3 documents, 2 guidelines, and one that robust ICT application for leprosy, through which we can register the new leprosy cases in our ICT portal, which is called NICUST 2.0, just like NICSOI 2.0. So from the document, I think we have a presentation from NPO, Dr. Rosmi, in this session only, who will speak about the salient features of those 2 guidelines. And before that, I have kept only one for this NSP and roadmap for leprosy 2023-27. So now the vision of the country, India, is that we have to make our country leprosy free with zero infection of disease, infection and disease, zero disability, zero stigma and discrimination by 2027. Not, please read 2027, not 2030. And goal also, I mean, that accelerate towards the achieving interruption of leprosy transmission. I mean, you have to bring interruption, you have to you have to cut the chain of transmission, otherwise you cannot, could not achieve the goal by 2027. First, we have to cut the chain of transmission. Whether you will consider the single dose rifampicin to cut the chain of transmission, or it may be, I mean, a little bit of social isolation of the index case for a period of 3 weeks of treatment, or it may be we have to, I mean, we have to introduce vaccine also to cut the chain of transmission. I mean, we have to give vaccines to the contacts of the index cases to cut the chain of transmission. And the specific objective, I mean, you will get the copies. We will upload the both the guidelines in our all websites, the ministry website, the DGH's website, the ICMR websites, all kind of websites. You can download it and read it. We have released the physical copy today. Definitely we will upload those guidelines. You will get a copy from our, if you visit our websites. So these are the specific objectives of the NSP document which we have released today. The first one is strengthen leadership, commitment and partnership. I have spoken about it, that we need, in every forum I always speak about that we need a good leader at every level, at the central level, at the state level, at the district level, at the block level, at the PSC level, at the health and wellness center level. Need good leaders. I mean, we need so many good leaders at different levels. So one good leader can change the scenario. This is my personal perception. I don't know whether you will agree with me. If you get one leader at your organization or institute, or maybe at your state leprosy cell, or maybe district leprosy cell, that person can change the scenario. I mean, that is the positive vibes of a person, you know. He can bring the change in the whole districts. I am talking about the district leprosy officer. If we get a good leader in the form of district leprosy officer, that district leprosy officer can bring a lot of change in the districts, in the concerned districts. So that kind of leadership we need, and commitment from the people, from all kind of people, all sorts of people, all stakeholders, and we have to build partnerships on a regular basis. We have partnerships with some of the international NGO, but we have to build new partnership also. Then acceleration of case detection, you know that we have to diagnose a case very early, so that we want to see zero disability by 2027. Zero disability in adults, zero disability among children also, and provide quality of service. And I can assure you, whatever medicines or whatever treatment regimen we are providing to the leprosy patients, that is of the highest quality in the world. So we are providing the highest quality of medicines to the patients, but only problem, there is a problem actually. Our private practitioners, I mean, there is no engagement of private practitioner in the country, because still leprosy is not a notifiable disease. We could not declare leprosy as a notifiable disease. So if you can engage the private practitioner, if they follow the similar kind of regimen as we are following, as that is depicted, as that is written in the NLP, I mean, I think 90% of the job can be done. So you know that all the dermatologists, the skin specialist, and other private practitioners, they follow different kind of regimen for leprosy patient. Even they don't refer the patient to our government health facility, they want to treat the patient themselves, and that is a problem actually. I mean, there is a chance of developing resistance, and we have released the document of AMR guidelines for the country also, and it is more than 3%, and for the new cases, I mean, that kind of resistance we have already, the leprosy patient has developed. Then enhanced measure for prevention and of that I have spoken about, and you have to ensure the human rights and dignity of all citizens, not only leprosy patients. I mean, you have to take care of them. I mean, so that the you have to ensure the dignity and respect, and for our leprosy patient also. And this is the second document, and which is called National Guidelines for Surveillance of Antimicrobial Resistance in Leprosy. Main objective is that to establish a nationwide robust surveillance system for AMR in leprosy. We got some, data, small data from pilot projects that speaks about the level of resistance of anti-leprosy drugs, but we need a robust mechanism in the country, and that's why we have released the document, guidelines today. I am hopeful that guidelines will be followed by all the stakeholders, not only our SLOs and the states, the DLOs and the districts, but throughout the country they should follow. To reduce the level of resistance of the anti-leprosy drugs in their country. And I am very glad to announce today that that has been also released today, our ICT platform, ICT portal, that is called NICUS 2.0. So far we are getting data through in the physical format or maybe in Google form from the states and UTs on a monthly basis only. So we need a ICT platform where we can register the cases on real time basis. If it is not possible on a real time, at least once in a week we can upload the data or register the leprosy patients in the ICT portal, so that we can get at any point of time the real picture, real scenario of the country, real scenario of the state and districts. So these are the immediate priorities. How to, I think our Honorable Minister has spoken about it, to search for the hidden cases. There are a lot of hidden cases because of that stigma and discrimination is attached to the disease. So we have calculated that figure also. So during the COVID period, probably we could not find out 66,000 cases. So what we have decided that in the next 2 years, 2023-24 and 24-25, we will find out 33,000 such hidden cases in a year. In the first year, 33,000 cases, apart from the normal new cases, 33,000 new hidden cases and 33,000 new hidden cases in 2024-25. And already we have released that document, so I have spoken a lot about that NSP. Then introduction vaccine I have spoken about. There are two kind of vaccines, that MIP and second dose of BCG. But we, because that MIP has got approval from the DCGI, so we can think about it. We had a meeting with ICMR, and ICMR is interested to introduce that vaccine. At least some of the states, some of the most prevalent states like Chhattisgarh and Odisha, Delhi, and that Jharkhand also, Bihar also. So if we get that vaccines in near future, and also if you can scale up the coverage of single dose rifampicin, then what is my goal? My goal is to cut the chain of transmission before 2027. By 2025. If we can cut the chain of transmission with the introduction of new vaccine and with scaling up the coverage of SDR, and giving some nutritional support to the leprosy patients, it would be enough for us to reach to the goal of 2027. And then that mental health counseling, we had one such workshop, how to integrate the mental health services for leprosy patient, and that was a very successful workshop. And we have prepared one framework for the country, how to connect. That is a draft framework that needs to be approved by the higher officials. So that will be scaled up in the country also, how to connect, how to connect our national mental health program for the benefit of our leprosy patient. That as because stigma and discrimination is there is always a problem of mental health illnesses, be it major or minor. And the prevalence rate is high, very high. More than 30%. That in case of depression, it is more than 60% among the leprosy patients, particularly the grade 2 disability patients. So I have spoken about the IT platform also, and that is the target by 2027. That I have You can read the first one, the leprosy elimination at the block level. I mean, at the district level, we want to achieve by 2025. At the block level, that is the final year of achieving the target. So at the block level, we have to achieve by 2027, and grade 2 disability less than 1 per million by 2027. And you can read the other. Priorities also, like diagnostic. I have talked about that we have to introduce lab diagnosis of leprosy. Otherwise, at the end of the program, we always talk about the release from treatment or complete treatment completed. Now, if you introduce the microscopic test and other test, the NAT testing, we can boldly declare that the leprosy patient is cured. We cannot call the leprosy patient as cured because of lack of diagnostic facility for the leprosy patient. Then zero discrimination and other things are there. So I think thank you very much. So thank you for your patience. Always I give a detailed presentation in every forum, and people get disgusted with me. That's such a long presentation. I don't want to hear from you. Please bring another presenter before us. Thank you very much. Thank you for your patience.
Thank you, sir, Dr. Sudarshan Mandalji, Deputy Director General Leprosy, for your presentation on National Leprosy Eradication Program and its recent achievements. Sparsh Leprosy Awareness Campaign, SLAC, ladies and gentlemen, is an initiative under National Leprosy Eradication Program that aims to raise awareness about leprosy and to promote early detection and treatment of the disease. Our next speaker, Dr. Avinash Santhalia, Senior Medical Officer Leprosy, will speak on Sparsh Leprosy Awareness Campaign. So it's over to you, please.
सम्मानित मंच, सभागार में उपस्थित हमारे वरिष्ठ अतिथिगण, आप सभी को मेरा नमस्कार। अभी एक विस्तृत प्रेजेंटेशन हमारे नेशनल प्रोग्राम मैनेजर डिप्टी डायरेक्टर जनरल भारत सरकार डॉक्टर सुदर्शन मंडल सर द्वारा की गई। तो सर, जैसा कि आप बोल रहे थे, आपने जो हार्ट और सोल है प्रोग्राम का, उसको बताने में सर टाइम लगता है। तो जो आपने टाइम लिया, मुझे लग रहा है वो भी कम था। यू शुड हैव टेकन मोर टाइम। तो जो मेरी प्रेजेंटेशन है, आई विल बी डिस्कसिंग अबाउट द स्पर्श लेप्रोसी अवेयरनेस कैंपेन। बिफोर आई स्टार्ट माय प्रेजेंटेशन, आई वुड लाइक टू emphasize upon the activity per se, that is the awareness, and what role it plays in elimination, or you can say eradication is a more ambitious word, in elimination or reduction in the number of cases of any particular disease. We are a huge country, a country of around 142 crores. If you want to make the people healthy, if you want to have the country healthy, it is not possible that we have all the 142 crore people in the hospitals. A health system should be such, the health system of any country should be such that it prevents people from going to hospitals. It prevents people from visiting hospitals. How do you do this? The first and the basic step is spreading awareness. If someone is aware, अगर कोई भी व्यक्ति समाज में जागरूक है उस समस्या के बारे में, उस बीमारी के बारे में, तो वो उससे बचाव के जो तरीके हैं वो अपने जीवन में उनको उतारेगा। इसको अंग्रेजी में बिहेवियर चेंज कम्युनिकेशन बोलते हैं। तो जागरूकता का कोई भी नेशनल हेल्थ प्रोग्राम के अंदर बहुत अहम योगदान है नंबर ऑफ केसेस को रिड्यूस करने के लिए, और जो हमारा टारगेट 2027 तक हम लोग एलिमिनेशन की तरफ जाना चाह रहे हैं, केसेस को ज़ीरो ट्रांसमिशन करना चाह रहे हैं, उसमें ये नीड़ का पत्थर साबित होगा। So this is a regular slide which everyone knows. What I want to emphasize in this particular slide is leprosy, if not treated, may lead to permanent physical disability, and we should be aware enough to spread timely diagnosis and treatment which is available. So leprosy is 100% curable provided we take the preventive measures, we are aware about the signs and symptoms of the disease. It mainly affects the peripheral nerves, the extremities, the skin, the nasal mucosa, and the upper respiratory tract. So this particular message has to be spread into the community about awareness. Why do we need awareness? There are basically two main objectives of this first leprosy campaign. First is to reduce the number of cases by promoting early detection. So if we are able to detect them early, we can start the treatment and we can achieve 100% cure. Second is to reduce the stigma and discrimination which is associated with the disease, because this affects the entire, not the present generation, but also the next generation. The children of the leprosy affected patients, they are also discriminated against by the society. So not only the leprosy affected patient, but the social status, the employment opportunities, marriage, family life of the children is also affected. So we have to have a very holistic view when we have to address this challenge of leprosy elimination. This first leprosy awareness campaign, it was an initiative which was taken under the Honorable Shri Narendra Modi ji, Prime Minister of India. We are into the 6th year currently. The first one was started on 30th January 2017. Basically, these are theme-based campaigns. In the earlier years, we used to have a 15-day fortnight campaign till 13th or 14th February. But as DDG sir has told that this year we will be having till 29th January. This will be a year-long campaign. The entire year it will be there. So even during the COVID-19 pandemic, there was a great response which was there from the grassroots workers, and everyone was totally involved in the program, although COVID was also a great challenge. And if we continue to have such response every year, we will be able to achieve the target before 2030, that is 2027, which has been decided by the Honorable HFM. This slide shows the impact of Sparsh Leprosy Awareness Campaign over the years, and we can very well see that even in 2021, we had 78% villages which were covered, and it has been over 65% through the years. Now, who are the key players who need to play a role in this? We have the state leprosy officers here in the audience. We have the partners, Samarpan Foundation Trust, Rashtriya Seva Bharati. We have some representation from ILEP. So along with the state government machinery and the other concerned stakeholders such as the Panchayati Raj institutions, rural development, urban development, women and child development, social justice and empowerment. So everyone has to contribute to the campaign. The last line, it is written as 30th January to 13th February. This should be read as 13th February 2023 should be read as 29 January 2024. It is a round the year campaign. It was a typo error. So what are the activities which are basically this campaign focuses on grassroots activities. Before I start, I will tell what is a Gram Sabha. Gram Sabha is a collection of individuals in a village above the age of 18 years, and they sit together to discuss the important issues. So we have made the Gram Sabha as the center point for this awareness campaign, and there are different SOPs which have been, I would like to say, guiding principles. Of course, they can do it as per their local needs and understanding, but a broad SOP has been laid down as to how they should undertake this campaign. I will quickly go through this. So the message from the district magistrate on the leprosy awareness: either the DM directly comes to the Gram Sabha meeting and he discusses, or other senior officials, the block level officer or the Gram Sabha Pramukh. Then appeal from the Gram Sabha Pramukh to all members for reduction of discrimination against persons affected with leprosy. Leprosy affected or a cured person, if he is there in the community, he should be made as guest of honor in such a meeting. That will build a level of confidence in the community and help in reducing the stigma and discrimination which is associated. The same person, he should be motivated to convey the IEC messages to the community. The theme for this year is Let's Fight Leprosy and Make Leprosy a History. This theme should be highlighted in all the slogans and banners which are to be made for this purpose. This I have already told. Apart from the Gram Sabha meetings, we can utilize the school, Anganwadi, Mela, religious places for IEC awareness campaign. In the audience, we have the partners who are working at the grassroots level. They have a very important role to play because they are connected with the local community. And whatever is being conveyed through them is well taken by the community. They already have a bond of trust. So that should be utilized for effectiveness of the campaign. Where is the sensor to this? Where should I am not able to do it. Okay. This has been already told. Next. I want to change from this. Sensor किस तरफ है वो बता दीजिए. So, another, apart from the Gram Sabha, another committee which is there, which works at the village level, is the Village Health and Sanitation Committee. This committee also is responsible for the implementation. And the partners who are working at the grassroots level, they should be a part of the Village Health and Sanitation Committee so that their role can be utilized. This particular event is to be facilitated by ASHA workers, multipurpose workers, with the involvement of the Gram Sevak, school teacher, PHC health center, or the sub-center staff at the village level under the supervision of the medical officer. With respect to the urban areas, the district leprosy officer may organize IC activities in the slum pockets of the urban PHCs with the help of NGOs. So this lists out the different activities which the Central Leprosy Division did for the last half months, over 2 months, so that this campaign can be smoothly launched in the country. Next. For better organization and management, it is proposed to formulate some special committees at various levels. I will be giving a detail. Next. So this is a state level coordination committee to coordinate the Sparsh leprosy awareness campaign activities in the state. The different members which are to be the part of the state level coordination committees are enlisted here. The state leprosy officer is the member secretary with the MD, NHM, DHS and the other organizations. And one of the key functions will be to finalize a plan for the entire state. Next. State Leprosy Awareness Media Committee. So, along with the grassroots level partners, media also has a very important role. The local Akashvani and Doordarshan Kendra will be represented in the committee. Next. I want to change it from here. अगर सेंसर बता देंगे तो मेरे लिए इजी होगा. मैं यहाँ से प्रेस करूँगा, उस तरफ है. लेट हो रहा है वो, ठीक है. So we have this district coordination committee at the district level, which will be chaired by the district collector, magistrate or CEO, and of course there will be other organizations. Next please. Tehsil level. Next. So at different levels we will have a coordination committee to look into all the activities, the detailed what are the actions which are to be taken, as well as follow up. The state leprosy officer is the main nodal person to coordinate everything in the particular state. Next, he has to sensitize the district level, the district leprosy officers. The district leprosy officer is the key person in the district. Next, the block level PHC medical officer. Next. So these are some of the news reports which I got through different state leprosy officers. They have sent it to me, as well as, so the campaign has already begun and everyone has, all the states and UTs, they have made a plan to make it successful throughout the country. Next please. So whatever we achieve in any health system, we have, apart from the clinicians, the entire ecosystem, starting right from the grassroots workers, ASHAs, ANMs, the medical officers who are working at the PHC, CHC, district hospital, the state government setup, the NGOs who are working there, the entire ecosystem has to support, and collectively we have to work as a homogeneous team to achieve the target. And there is no doubt that anything can prevent us from achieving the target by 2027. Let us fight leprosy and make leprosy a history. Next. So I would like to sign off with these words. Sarve santu, sarve bhavantu sukhina, sarve santu niramaya, sarve bhadrani pasyantu, ma kaschit dukh bhag bhavet. सभी सुखी होवें, सभी रोग मुक्त रहें, सभी मंगलमय घटनाओं के साक्षी बने और किसी को भी दुख का भागी ना बनना पड़े. नेक्स्ट. इसी मंगल कामना के साथ मैं अपने वक्तव्य को विराम देता हूं. आप सभी को मेरा नमस्कार.
बहुत बहुत धन्यवाद डॉक्टर अविनाश सुंथलिया जी. Thank you so much. Dr. Avinash Sunthalia ji, Senior Medical Officer Leprosy, who spoke on Sparsh Leprosy Awareness Campaign. The National Strategic Plan NSP and Roadmap 2027 and AMR, that is Antimicrobial Resistance Surveillance guidelines are developed by the Ministry of Health and Family Welfare to eliminate leprosy as a public health problem by the year 2027. I request Dr. Rashmi Shukla ji, National Professional Officer, Leprosy WHO, to take us through the salient features of NSP, Roadmap and the AMR surveillance guidelines. Ma'am, please.
A very good afternoon to everyone. Most respected Dr. Sudarshan Mandal sir, DDG Leprosy, Dr. Avinash, Madam Lily, and all the very, very dedicated leprosy fighters of the country. Don't go by these empty seats that are left here. I must say this country has scores, hundreds of leprosy fighters, very dedicated. They have not been able to make it to this room, but they are all there all across the country. So let us all be feeling very strong, very encouraged that we all are here and we have this fight. We have this unfinished business, and in this lifetime, we have to achieve it. So this National Strategic Plan and Roadmap for Leprosy, this has been a dream for many of us. Because for the last many years, we were going on with the things that we already had in our portfolio. But here came an opportunity where all of us came together. You will find it hard to believe, but for the last many months, 80 to 90 people have been working on what should be done in India to arrive at something which we can call a substantial gain, something that will have a promise of a leprosy-free India. So this document was made by first analyzing what is happening in the country, what is not able to happen in the country. So this is a document which has a lot of ambition in it. But then all we need is to have faith that if we do what is written in this guideline, we can achieve what we are setting out to achieve. If we don't have that faith in us, then nothing can be done. So let us have faith that 80 to 100 experts of the country have put together their ideas. And here I must say that this document is certainly a part of the global guidance, but this document has been put together by the inspiration of Dr. Anil Kumarji, our Additional Director General, Ministry of Health and Family Welfare. Every little word in this document has been seen by him, and he has faith in this document. And he has immense experience, and we have as contributors the directors of all the regional research and training institutes of the country. We have senior regional directors who have contributed, all the ILEP NGO representatives who have been working in India for decades and decades. So this is a very I would say a very sacred document. So let us believe in this document and move forward like our the WHO representative said, that we have to translate it in letter and spirit. So here we are. Let us just have a glimpse of what is there. Of course, it is only a strategic plan. The nitty-gritties of how each of these strategic directions will be put into action is what we will be seeing here. So the strategic pillars you have just seen in the global strategy document, in that we have 4 pillars. India, of course, having, half of the global load, needs some extra pillars as well. So we have 5 pillars. So the first pillar is about strengthening leadership, commitment, and partnerships. So that is one big pillar. I will discuss each of the pillars one by one. Second is accelerating case detection. Now, it was already mentioned in our DDG's presentation that we hope to achieve the active case detection and all the other goals. So for that, for the achievement of interruption of transmission towards which we are moving, it is very important today that we accelerate our case detection. Otherwise, what is happening? We are finding the cases, treating them, and by then we already have a big load of new cases that have arisen in the community. So here we have to accelerate case detection to a level that we find them so early that they don't give rise to the new infections. The third pillar, quality services. Of course, we are all here to serve the people who are suffering from this disease, who have this disease and need treatment. The next pillar is prevention. Prevention of the disease, prevention of disabilities, prevention of stigma, discrimination, and preventing the violation of human rights. So this was a different kind of pillar that we built for ourselves. And the last pillar for Digital India, leprosy program is one program which is still not fully digital, so digitalization. Next one, please. So as per the timeline that has been set in this document, of course, when we started off with this document, our target was 2030. But then, because India is, always trying to be a little more prepared than the target line, this target was brought to 2027. So the finishing line for this roadmap is 2027, and we have 5 years. So in these 5 years, the initial few years will be accelerating. The next 1 year will be sustaining the momentum, and then of course moving on to targeted interventions and continued surveillance. Presently, India is kind of halfway towards the goal, you can say. And that halfway is of course those low endemic states that have always been low endemic. So we have this other half which has a lot of work to do. Next, please. So the first pillar is about leadership, commitment, and partnerships. Nothing can happen without a good leader, sir already said, Dr. Mandal. So I fully agree with him that good leaders at all levels can make all the difference. So how do we have these good leaders? We have to convert our program managers into leaders. Because being a program manager is not going to be enough for a disease like leprosy. Because in many programs, if you just give treatment to a patient, that is all. Here it is a disease which is not only within the domain of the health department. It goes beyond. It goes towards livelihood and laws and discrimination and social justice and empowerment. So here our district leprosy officers, our state leprosy officers, the national program manager, they have to bring together lots of partners together and be a true leader, and under that leadership all the partners can coordinate, cooperate, and come forward with the achievements. Now, whenever there are too many instruments playing, then to make sure that it doesn't turn into a noise but it becomes an orchestra, you have to have that person who moves the hand like this in an orchestra. So the program managers have to really handle all the partners well and monitor the activity that is being done. So monitoring cells at the national, state and district level has to be kept in place if we are planning to move very fast. And whenever we have a disease program where patients have to be taken care of, then the service providers have to be trained. The expertise of the service providers becomes very critical in leprosy because they have to treat in a way to prevent disabilities. And any lapses here or there can change a person's outcome of treatment. So a lot of training has been planned, and blended trainings where you have the virtual as well as the physical trainings. And just keeping in mind that we are escalating the introduction of single dose rifampicin, so antimicrobial resistance has to be put in place. So introducing a countrywide surveillance program for AMR, that is also in the document, and then integrating with IDSP for suspect referral as well as for monthly progress report submission, which will be a little different from NICUST. Where NICUST has the data of all the patients, the IDSP IHIP portal will be generating the monthly progress report, the drug stock positions in a way that it is real time and the program functions well. Introduction of new interventions, we all have to move with the times, and any new vaccine coming in, any new diagnostic tools, all have to be imbibed in the program. And of course, the partners, we need more partners. I think this is something that the program realizes, that we need more donors and more partners if we plan to accelerate. Next slide, please. So accelerating case detection, of course, the Sparsh campaign, which will be there for the entire year, and every other possible means of communicating with the people is what needs to be done. Everyone should know about leprosy, just like all of us knew about COVID. Ask anyone and they knew about COVID. I think we have to make a mass movement like that for leprosy, because this is a problem which cannot be tackled otherwise. We have to promote self-examination. Now, how much can we go from door to door and examine people? Examining people's body is not an easy job. We may consider it, oh, we have to just go and we have to ask them. See, many people don't know they have a patch on their back. Many of their houses are so dark that when a health worker goes, they are not even able to see the patient well. So self-examination here becomes very important. We all have to volunteer and check ourselves. So let us include in our awareness campaigns self-examination. Then incentives. We always feel that incentives work, so why not? If there have been incentives like 5,000 if you report a case of yours, why not leprosy? So in leprosy, anyway, in the program, we have 250 rupees to anyone who finds a case, refers a case, and if the case gets confirmed, the person gets 250 rupees. But presently, it's mainly for the ASHAs. Though in the government order, general public could also avail it, but they are not availing it. So I think that needs to be kind of publicized. The message has to be publicized, and the referral of suspects should improve by that activity. So active case search campaigns, India has already divided all the districts and the blocks. You can see in the strategy document that all the districts and the blocks have been divided into four categories, depending upon the ANCDR and the grade 2 disability. And they are classified as highest, high, moderate and low. So accordingly, the campaigns are to be planned. The kind of investment, the repetitions of active case search campaigns will depend upon the category under which the district or the block falls. Integrated case search, nowadays we are having so many other programs where we are having case detection, door-to-door health education. So leprosy has to be integrated. We can no longer continue as a vertical system. We have to integrate with other programs. And the one big thing that India is now trying to improve upon is contact tracing. And in this document, we say that not only examining the contact for the first time, but contacts have to be followed up, because leprosy appears in a person maybe after 2 years, 3 years, 4 years. So we have to repeatedly re-screen the contacts. Next slide, please. Then quality services. It is our big dream always that we have to give comprehensive package of services. A patient should get all the services that are due to him. He has to be diagnosed correctly. He has to have examination of the hands and feet every time he comes to the hospital. The mental well-being, the physical well-being, any comorbidities. So comprehensive package of cares is what is planned in this document. Uniform criteria for management. Now some people give a treatment for 1 year, some in the private sector give it for 3 years. So there has to be a uniformity so that, you know, every patient gets what is right in the name of treatment and management. Coordination with medical colleges. Sir has already mentioned that medical colleges, private practitioners are still not with the program. They are still working in their own silos. They do not send us the reports. Now, if a private practitioner treats a leprosy patient and does not tell us about the patient, how are we going to how are we going to carry out the contact tracing of such patients? So we have to have the private sector's report with the government health facilities. They can continue to treat the patients at their end if the patient wishes. And if the patient wishes, the MDT can be delivered to the patient's doorstep. And otherwise, the report has to come to the government. Otherwise, even other logistic support like the self-care kit and MCR footwear, we will not be able to give to those patients who are in the private sector. Then supporting facilities like incentives, pensions, housing schemes. Somewhere the health department is in touch with the patients. So if we are very well informed about the different government schemes, we can facilitate the leprosy patients getting these services. Child leprosy and leprosy during pregnancy. Now, you know, as we have fewer number of cases now, our quality of services has to increase. And certainly child leprosy is the big concern. It has been made part of the global targets. So child leprosy has to be paid more attention. And now there are, papers being written that those who are pregnant, the pregnant women need more attention when they are being treated for leprosy and its complications. Similarly, the program now plans to have pharmacovigilance of any adverse drug reactions, be it from SDR or any vaccines which we introduce in future, or the regular MDT. Next slide, please. So the next pillar is preventing disease, disability, stigma, discrimination, and protection of human rights. I think most of these figures have been covered. But only one point I would like to say here is that high-risk patients, like in leprosy, if one person suffers a reaction once, the chances of suffering a second round of reaction becomes 4 times. So such patients who are at risk of developing recurrent reactions, they should be marked as high-risk patients and they should be followed up better for good treatment outcomes. Next, please. Digitalization, I've already discussed that we plan to integrate the leprosy reporting with the IHIP portal. Quite a bit of the work has already been done, and hopefully in 2023 itself, we will have monthly progress reports being generated on the IHIP portal. And this also has the drug supply integrated into it. Next, please. So next is the national guidelines for AMR surveillance. Next, please. So we already know what is in this document. In a phased manner, India is going to expand the AMR surveillance, and it gives a guidance on how to collect the smear, how to put it in the little bottles in which they have to be transported. So the entire details of how to transport the sample for AMR testing, how to report, how to record, all that has been included in this guideline. So these are some of the figures of the kind of resistance we have in the country. So we have not collected much data on this because only very few centers had been receiving samples. So you will see here that from 2010 to 2015, resistance to rifampicin among new cases was 3.5 and among relapse cases was 8.3. And to dapsone, it was 2.2% among new cases and 4.9 among relapse cases. We have some more recent data. Thankfully, it says 0 clofazimine resistance, 3.1% with dapsone and 4% with rifampicin. So these guidelines are for the district and the state level program managers, and we already have some training videos developed by Central Leprosy Division in collaboration with WHO on how to collect the sample, how to send it. So these training videos are very short videos. They show how to do the entire procedure, and so training won't be so difficult if we have an online platform. Very soon we are going to put all these training modules, these video training modules, for open access by all the program managers, in fact anyone and everyone. So these are the reference labs that we have presently. We may have to build a few more as we scale up the AMR surveillance, but these are the 7 that we have. Some of these are run by NGOs and some belong to the ministry. Next please. Thank you so much.
Ma'am, do we have time for the question answers? It's already one. Well, thank you, Dr. Rashmi Shukla ji, National Professional Officer, Leprosy WHO, for throwing light on the National Strategic Plan and Roadmap 2027 and AMR surveillance guidelines. So, although we have some time constraint, but 1 or 2 questions if any of you have, please. Any questions? Yeah, please. Yeah, please. Introduce yourself, please, first, and then ask a question.
Hello, everyone. My name is Gaurav, and I am a student of Jawaharlal Nehru University. Ma'am, I have 2 questions to ask. The first question is, what was the reason for increase in the number of cases in the grade 2 disability cases in India? Although we know that the COVID case was prevalent all over the world, is there any specific reason for it? And the second reason is in our policy that we are having. Hello, ma'am, 2 of my questions I want to ask. The first one is that what was the reason for the increase in the number of cases related to the grade 2 disability in India? Although we know that there were other countries also which were like affected by COVID. What could be the reasons behind it? And the second one is, what are the incentives to promote the research and development in the case of like resistance to drugs that we are talking about? Is there any specific policies that we are working this in regarding to leprosy?
No, we don't have that increased number of grade 2 disability in the country. Actually, that has been decreasing year-wise. And I have shown one slide, that I mean, we always we have an indicator. We consider grade 2 disability, percentage of grade 2 disability among the new cases. Okay, so that has been decreased from the level of 20% of the total new cases to at present I think 2.47 or 2.5%. So there is a huge achievement as far as grade 2 disability percentage among the new cases is concerned. What was your second question?
So second question is, as we are talking about and as we are worried about the resistance to the drugs that we are offering, so what are the specific policy guidelines that we are working upon for the research and development for in this area? Like any specific policies?
Yeah, regarding AMR, antimicrobial resistance.
Yes, sir.
So you know that we don't have, I mean, vertical setup, that laboratory setup to detect the antimicrobial resistance for our program itself. But all the programs are working under National Health Mission. So what we have decided in the meeting under the chairmanship of Dr. V.K. Pal, member Niti Aayog, that there is a huge vast network of TB program, National Tuberculosis Eradication Program. So, I mean, both the programs are working under NHM. So that huge network of TP program, they have, you know, 3 NLR, I mean, national level reference center. National level center 3 are there, and 29 state level, I mean, that is called IRL, Intermediate Reference Laboratory. And also the district laboratories and state laboratories, everything. So we have to use their network for detecting the resistance, and they have also gene sequencing setup in their program. So we have limited number of cases only. They have 20 lakh cases of new cases for tuberculosis. We have limited number, only more than 1 lakh cases. So they have agreed also. I mean, they have to agree. There is no other way. So we will involve National Tuberculosis Eradication Program and their laboratory setup for our program, for our NLAP.
Thanks a lot, sir.
Any other question? Yeah, please. Can you please pass on the mic, please? Thank you.
One is a suggestion, another is a question. Has the time come for us to change our leprosy institutes into tropical diseases institute? Remove the word leprosy. Number 1. Number 2 is regarding, have we also have to include our RCS and all the so many surgeries being done for leprosy patients in our Pradhan Mantri scheme, insurance scheme? Because till now it is not included. So can we include that in that scheme so that...
What is not included?
The RCS and the other surgeries which are done for the leprosy patients. So if it is not included, it may be included.
It is included actually.
But it's...
So I am giving, let me answer to Dr. Joe. I mean, good suggestions and questions also. The first one regarding, I think, what is your first question? To making, I mean, converting the all 4 leprosy institute into tropical disease. No, we have taken a decision to set up one, I mean, it should not be called neglected, the focused tropical disease center at Gauripur, Bankura, West Bengal. That policy decision has been taken by our honorable, I mean, respected DGHS. So we are going to set up one nodal center for focused tropical diseases, and for the other 3, I mean, we have different type of ideas in minds, and that has to be implemented. Particularly for that, you know, Raipur RLTRI, that will be made the nodal center for RCS and other also, and I think your center is a national center actually, Central Leprosy Institute. So we have different ideas for other 3, but we will set up one NTD or focused leprosy, focused tropical disease center at Gauripur. That is in mind. And regarding your second questions, insurance, that is already included. RCS is included in Pradhan Mantri Jan Arogya Yojana.
Yeah, ma'am, you have one question.
In case of inpatients, okay.
Yeah, please. Yeah.
So one question and a couple of suggestions. The question is, before I come to that, thank you, a very nice presentation, and Dr. Rashmi, that was very, very insightful, the presentation, and where you mentioned about support services. Now the support services are very, very important, and it's very new. So what would be the nodal point for people to access support services in this? And 2 suggestions. One is about Sparsh leprosy campaign. Like when the pandemic came to India, that time Niti Aayog got all the other partners, especially NGOs, who are present in the hard to reach areas, and gave them a whole set of creatives and the awareness campaign to take it forward. So maybe in this also, and a brilliant thing of not doing it only for 14 days but for doing it for the entire year, I think that's really good, will really help in accelerating it. So not just NGOs working in the leprosy sector, NGOs working across would be very happy to be a part of this mission, and I think it's time that we disseminate the Sparsh leprosy awareness campaign to everybody and ask them to join hands in taking this forward. And the second suggestion, which I've been talking since very long time, sorry, is we should not have the word anti before the leprosy day, because there's nothing like anti-cancer day or anti-TB day. It's only in leprosy that we have this all over the world. So maybe just a National Leprosy Day would be very good, and we remove the word. I know it's a long process, but if we start the process and do it before next year, that will be great. Thank you.
Right. Thank you, ma'am, for your suggestion and question. So now with this, we'll round up.
I would like to add to, we have, he is a very young research scholar in GNU. बहुत अच्छा प्रश्न इन्होंने पूछा. दो बातें जो इन्होंने पूछी, he had a very good listening to the discussions. मैं एक बात सभी ऑडियंस के लिए बोलना चाहता हूँ कि जब भी हम लोग हेल्थ डेटा को देखते हैं, 52% लेप्रोसी के केस लोड हमारे देश के अंदर है. वो इसीलिए है कि हमारी जनसंख्या 142 करोड़ है. तो इसलिए अगर हम उसको पर मिलियन देखेंगे तो उसमें हमारे जो केसों की संख्या है वो बहुत कम है. और जो टॉप 3 देश हैं लेप्रोसी की केसेस की संख्या में, उसमें हमारा शायद तीसरा स्थान है, और वो भी इंडोनेशिया के नीचे है. तो इसलिए इसमें बहुत ज़्यादा हमें घबराने की ज़रूरत नहीं है, लेकिन हाँ, जागरूक होने की बहुत ज़रूरत है. और हमारा हमेशा ये प्रयास रहना चाहिए कि लेप्रोसी हमारा जो है ज़ीरो ट्रांसमिशन 2027 तक हो, और इसमें हम हमेशा आगे बढ़ते रहें. धन्यवाद.
I'm afraid, sir, we have some time constraint because we already actually... Yeah, okay, please, please. Please. No, it's okay. So let that be, please. Please, sir, carry on. Yeah, please. Yeah, thank you so much. So I'll invite rather Dr. Anjali Chauhan ji. Okay, sir,
क्या
please.
पूछना चाहते हो पूछो.
Respected all senior faculties and experts from all over India, and sitting on my right side is young generation, sitting on the right side, left side is young generation and right side is the generations who have seen participating in the mode. सर बस वो क्वेश्चन पे आ रहा हूँ. सब क्वेश्चन नहीं है, मैं ये यंग जनरेशन की बात को कहना चाह रहा था कि इनका क्वेश्चन ये था कि जो डिसेबिलिटी पार्ट शायद इन्होंने सोचा कि कंपेयर किया कि डिसेबिलिटीज़ हमारी कंट्री में है, कितनी ज़्यादा है कितनी कम है, वो इवेल्यूएशन का विषय है. बट मुझे ये लगता है कि इनके मन में ये बात है कि डिसेबिलिटी हो रही है तो क्यों हो रही है, और आर वी इन पोजीशन टू एड्रेस द डिसेबिलिटीज इन हैपनिंग, आर वी इन पोजीशन टू आइडेंटिफाई द डिसेबिलिटी इन अर्ली स्टेज. वो मैं यंग जनरेशन को, इन लोगों को सलाम करता हूँ, ये आगे आएँ और हमारा साथ दें.
थैंक यू.
नहीं, आप तो पॉलिसी मेकर हो, आप ही आंसर करोगे ना इसका. डिजेबिलिटी कम हो गया, परसेंटेज ऑफ डिजेबिलिटी अमंग न्यू केसेस दैट हैज बीन रिड्यूस्ड ड्रास्टिकली, कम, बहुत कम हो गया. Thank you. And over
may I
to
request Dr. Anjali Chauhan to please come onto the dais and felicitate Dr. Sudarshan Mandal ji, Deputy Director General Leprosy, with the memento. So it's a token of thanks. Yeah. I request Dr. Vijay Dhange ji to please come onto the dais and felicitate Dr. Avinash Santhalia ji, Senior Medical Officer, Leprosy, and kindly present a memento. I now request Dr. Abhishek Khanna ji to kindly come onto the stage and felicitate Dr. Rashmi Shukla ji, National Professional Officer, Leprosy, WHO, by presenting a memento to her as a token of thanks. So thanks to all the speakers. Thank you so much. So with this, we conclude, we round up our first session. And now, ladies and gentlemen, there is a lunch break. Although it was for 45 minutes, but now I'm afraid it's already 20 minutes past 1. So 1:45, shall I say? Request everybody to reassemble.
I think we can start at 2 p.m. We have 40 minutes, and 40 minutes is enough for lunch, I think. And we will have small lunch only. Very small lunch.
So we have got the grace of 15 minutes. So please make sure, it's a humble request that kindly join by 2. Thank you so much and have your grab. Thank you. Chan from WHO. Shri Ravi Prakashji from Samarpan Foundation Trust. Dr. Ashok Agarwal from the International Federation of Anti-Leprosy Associations. And Dr. Sanjay Pandeyji from Global Health Advocacy Incubator. So welcome back, ladies and gentlemen. Today, as we are observing National Anti-Leprosy Day under Ministry of Health and Family Welfare, Government of India, and theme is Let's Fight Leprosy and Make Leprosy a History. So after this lunch break, now we'll resume our today's event and proceedings with the panel discussion on role of development partners in National Leprosy Eradication Program. So Dr. Anil sir will chair the session, and as you can see, our panelists are already here on the dais. So, sir, I hand over to you, please. Jay, thank you, sir. Technical team, please. Yeah, sir, it's working now.
Thank you. Okay, so thank you very much. So I welcome all the four panelists on the dais. Dr. Pauline Chan from WHO, Sri Ravi Prakashji, Samarpan Foundation Trust से, Dr. Ashok Agarwal ILAB से, और Dr. Sanjay Pandey, GHAI. So GHAI is, maybe if you do not know, just for the Global Health Advocacy Incubator. So during the panel discussion, there will be total 8 questions, 2 from each panelist, and then if we divide the total time available, 45 minutes, so the panelists will have 2 to 2.5 minutes to answer the question. So I start with the first panelist, Dr. Pauline Chan from WHO, and madam, the question for you is, how can we bring about integration of National Leprosy Eradication Program, NLEP, with other national health programs?
Thank you very much, Dr. Anil, and good afternoon to everyone. I hope you had a good lunch, and hope these discussions will be very active, and to have also some discussions from the audience as well. I have a couple of thoughts on integration and what it means. Overall, we need it. We need, whether you call it integration, or I prefer the word convergence, or you want to say linkages, that's okay, because everyone understands these 3 terms differently. Integration in many countries that I've worked on talks about being competitive, being removal of funding to another program in some ways. So what I tend to do is say, let's do convergence of programming, of resources, because essentially it is the same health systems and services that we are working with. It is the same mental health people, it's the same counselors, it's the same ASHAs, ANMs, Anganwaris. Anganwaris do have a role. They can screen because they're looking at children all the time and women. So every functionary in the massive health system of India can have a role. It's just about mapping it out. So let's just start with that thought. And what do I mean about convergence of NLEP or leprosy with the other programs? And I will say that it's not just only other health programs, it's also about other sectors as well. What is important is to understand for leprosy is at this stage where we are in, and we are gunning for the last mile, for a no transmission strategy, for picking up the last and to stop transmission. So we really need to make sure that we can detect. The entry gateways are important. What does it mean by entry gateways? We leverage every functionary out there, because in Ashas you have 1,000 of them, no, 1,000,000 of them. In Anganwaris, how many millions do we have? Don't they have a role, even just to eyeball and screen and say, okay, this kid has a problem? It's schools, it's teachers, they all have a role. So it's just to leverage this whole of system approach and understand every person does have a role. So looking at that, that is possible. The other part of the multi-sectoral part is really so mobilizing all this workforce for an active case detection, even passive case detection. Let's screen, let's look at patches. Maybe, for girls, you can also ask girls to look at each other. They look at each other. They are concerned if they have patches. And very importantly is we have a very strong health care system in the sense that there's health programs that are invested. There's Kala Azar programs, there's LF programs, lymphatic filariasis. The TB program is down to the block level as well. There's door-to-door health campaigns done by virtually every municipality or state or district. The Dashta campaign for vector-borne diseases is done regularly. Orissa does it regularly. Recently, I heard Assam did leprosy with TB screening among tea plantations. So there is opportunities like this where you can leverage and make it a principle that leprosy is included. Only then we can move the active case detection forward and prevent early detection and prevent disability and deformities. One other thing, I do think that there is a possibility to leverage. As the program is moving forwards to the next year towards the SDGs, antimicrobial resistance surveillance is a new part of the strategy, AMR. So there is opportunity to use the existing AMR networks across all the states, but also the current government investment in public health labs at the district level. That has to be a point of opportunity. And I talk about opportunity because at the end, it's brilliant to have all these ideas, but we must act. If we want to make it operational, we have to push the system to work, because the system can work if you push it to work. And this is the same all over the world, not just only in India. Lastly, in care, support, and management, treatment of people affected by leprosy and with leprosy, mental health and well-being is one of them where we need increasingly more support. And there's an expanding network of mental health services. Geriatric and elderly care is a component that is required going forwards, because while India benefits from a fairly young demographic, at some point this will change. And many of our leprosy affected people are already in their older generation, but we still haven't switched off the tap of the newly infected. We have still children born or children who are affected with disability. We have I've seen young women who are affected with leprosy. So that tap is not switched off. And increasingly, we will need to find ways and work with other programs to give them mental health, social welfare protection, help them with comorbidities such as diabetes, hypertension. But in particular, for children and women who were affected really young, we have to go help them through their life course. Children need to grow up to young people. They will have to deal with that disability. They have to be married. They will face this stigma discrimination. We have to repeal all the discriminatory laws. All these things require a multi-sectoral, beyond health, all of government. We need people, we need society, we need you who are activists, who are health activists, to come on board and help us move and advocate for this. So lastly, at the end of it is, how may we use the common integration or the convergence platforms to provide for livelihood? At the end, people affected with leprosy will require economic protection and also livelihood, the means of livelihood. When we work, we feel good. If we don't work, well, we don't have a point. So I think this is a very important part of the overall well-being of getting everybody to come on board. It is possible, many schemes are there. It's about connection and linking everyone, the affected people in, and making sure that all partners and stakeholders are on board. Thank you.
Thank you. So the message is very, very clear that if we have to achieve zero transmission of leprosy, then we need to pool all resources available in the country. And then each and every partner, they must know what they are expected to do, so that we can effectively coordinate to achieve what we want to achieve. अगला जो सवाल है वो श्री रवि प्रकाश जी से है, जो समर्पण फाउंडेशन ट्रस्ट की तरफ से आए हैं, और आपके लिए मेरा सवाल है, क्या आप हमें समर्पण फाउंडेशन ट्रस्ट के कार्यों के बारे में विस्तार से बता सकते हैं, और समर्पण फाउंडेशन ट्रस्ट द्वारा कुष्ठ रोगियों के लिए सामाजिक गतिविधियों पर प्रकाश डालेंगे? तो आप बताएं।
समर्पण फाउंडेशन ट्रस्ट पिछले 25 वर्षों से प्रत्यक्ष रूप से कुष्ठ रोगियों के बीच में काम करता है। संस्था का उद्देश्य है, जहाँ भी जो भी सज्जन एमडीटी कोर्स कर चुके हैं सरकार का और कुष्ठ रोग से प्रभावित हो गए हैं, उनका दिन प्रतिदिन, चूँकि उन्हें या तो अल्सर है या तो उनके नसों में थोड़ा बहुत खिंचाव रहता है, और भी हेरिडेटिकल बीमारियों के वो शिकार भी होते रहते हैं। तो हमारा जो मेन उद्देश्य है वो ये है कि उनके अल्सर की पर डे अपने चिकित्सा केंद्र के माध्यम से पर डे उनकी अल्सर की केयरिंग करना। दूसरा, चल चिकित्सा के माध्यम से जहाँ जहाँ कुष्ठ आश्रम है, अभी तक हमने पंजाब, हरियाणा, राजस्थान पूरा, दिल्ली और उत्तर प्रदेश में लगभग सभी कुष्ठ आश्रमों में प्रत्यक्ष रूप से जाके उनके बीच में उठना बैठना, उन्हीं के यहाँ भोजन भी करना और उनकी संपूर्ण चिकित्सा अपने मेडिकल टीम के द्वारा करना और उनकी एक एक बात की जानकारी लेना। यह कार्य हमारी संस्था मेरी संस्था का एक काम ये है। दूसरा काम यह है कि जो उनके बच्चे हैं जो सोशल स्टिग्मा के शिकार हैं, कुष्ठ रोगी की जो व्यथा है वो उसके बाद की व्यथा है, जब उनके संतानों पे जाके पहुंचती है। जब किसी कुष्ठ रोगी के बच्चे को कोढ़ी का बच्चा कहा जाता है, उस समय प्रॉब्लम होती है। तो इस पे हम दूसरा काम कर रहे हैं, जगह जगह अपने विचार के लोगों से बातचीत करके इनके बच्चों के पढ़ने की संपूर्ण व्यवस्था का ऐसा कार्य कर रहे हैं। फीमेल चाइल्ड के लिए वनवासी कल्याण आश्रम के माध्यम से 173 कन्याएं रुद्रपुर में हैं। वो उत्तर प्रदेश, पंजाब और हरियाणा कुष्ठ आश्रमों की कन्याएं हैं। और उन बच्चों का टेस्ट भिन्न भिन्न स्कूलों में करा के जो उनके अंदर एबिलिटी है उसी के अनुसार उनका एडमिशन कराना, उनको पढ़ाना। और ये कार्य हमारी संस्था फीमेल चाइल्ड के लिए। मेल चाइल्ड के लिए 30-35 बच्चों का एक ग्रुप इकट्ठा करना, और जो बच्चे जुवेनाइलाइज हैं, 12th बिफोर के बच्चे हैं, उनको हमने कबीर की निर्वाण स्थली मगहर, मथुरा, कैथल और कुरुक्षेत्र में इन 4 जगहों पे क्षमता के अनुसार बच्चों को एक जगह रखना, उनको भिन्न भिन्न स्कूलों में एडमिट कराना और फिर उनको पढ़ाना। आदरणीय अनिल जी और WHO की टीम थी जब हम लोग अभी रांची के कुष्ठ आश्रम में विजिट करने गए थे, तो साहब के सामने एक समस्या एक कुष्ठ रोगी ने रखी थी, मुझे वो बात ठीक से याद है। वो बात ये थी कि कहीं का कुष्ठ रोगी और कहीं की कुष्ठ रोगिणी जब आपस में मिलते हैं तो उनमें कास्टिज्म फैक्टर तो होता नहीं, क्योंकि बीमारी की कोई जाति नहीं होती, उसका कोई। तो ऐसे बच्चों की भी मेरे पास पर्याप्त संख्या है। इस वर्ष हमने 16 बच्चों को हायर एजुकेशन में डाला है, उनको रोजगार परक शिक्षा दिलाना जो हम उन्हें कर सकते हैं, नर्सिंग ट्रेनिंग, BSc नर्सिंग, पॉलीटेक्निक से नीचे तो नहीं, ITI नहीं कराते, इतना तो चाहते हैं कि कम से कम इतना तो कह ही सके कि हम इंजीनियर हैं। दूसरा काम हमारी संस्था ये करती है कि हायर एजुकेशन के बच्चों को ऑर्गेनाइज वे में उनकी फ़ीस की चिंता करना, उस स्कूल से एसोसिएट करना कि वो स्कूल उनके रहने की व्यवस्था कर दे। हायर एजुकेशन में है तो स्कूल के अंदर कुछ पार्ट टाइम जॉब भी करे, फीस हम दे देते हैं, बाकी रहने खाने की व्यवस्था वो इंस्टीट्यूशन करती है। तो इस दिशा में जन जागरण का काम हमारी संस्था तीसरी रूप से ये है। और चौथा, एक हमने मोटो लिया था आज के 25 साल पहले कि कुष्ठ रोगियों की जो पीड़ा है उस पर समाज का दृष्टिकोण क्या है, तो इसके लिए हम जगह जगह सेमिनार ऑर्गेनाइज कराते हैं और जो भी अपनी विचारधारा है उसको हम उनमें डालने का प्रयास करते हैं, ताकि वे बच्चे खुद अपने माँ बाप से घृणा न कर बैठें। भाई बच्चे मान लीजिए इंजीनियर हो गए, अब वो क्यों जाएं, तो उनके भी अंदर एक संस्कार आए, इसके लिए भी हम सतत प्रयास करते रहते हैं। इसलिए हमने एक अपना नया मोटो बनाया कि कुष्ठ रोगियों की पीड़ा और उसमें समाज का दृष्टिकोण क्या है। तो इस पर जगह जगह सेमिनार करा के और ये काम हमारी संस्था करती है। भविष्य में मुझे 6 स्टेटों में और काम करना है अभी जाके अवेयरनेस के लिए, जिसमें हमने निर्धारित किया है उड़ीसा, झारखंड और गुजरात। अभी 3 प्रांतों में अभी अप्रैल तक इसको पूरा करेंगे, अप्रैल मई में। फिर उसके बाद, चूँकि मेरा लक्ष्य यह है कि हर कुष्ठ रोगी के घर तक पहुँच के उनको उनकी बात बताना, उनकी समस्या को समाज को बताना, ये मेरा उद्देश्य है। चूँकि WHO भी इस बात को मानती है और हमारा पूरा समाज भी इस बात को मानता है। सरकारी आंकड़े तो पूरा हो जाएंगे, लेकिन जब तक समाज खड़ा नहीं होगा तब तक उसका उन्मूलन सही प्रकार से संभव नहीं हो पाएगा। जय हिंद, जय भारत।
मैं श्री रवि प्रकाश जी को इतना नोबल कार्य करने के लिए मैं उनको बधाई भी देना चाहूँगा और उनका धन्यवाद भी करना चाहूँगा कि वो इस तरह का काम वो और उनकी संस्था कर रही हैं। मैं ख़ास तौर से इस बात पे आप लोगों का ध्यान दिलाना चाहूँगा जो उन्होंने कहा कि वो सिर्फ जाके कार्य नहीं करते, उनके साथ बैठते हैं और उनके साथ उनको मिल करके उनके बराबर के स्तर पर जा कर के उनको सहयोग करते हैं। एजुकेशन जो है वो जो लेप्रोसी अफेक्टेड लोग हैं, एजुकेशन उनके लिए बहुत ज़रूरी चीज़ है, क्योंकि एजुकेशन से ही एम्पावरमेंट आता है और इसी से वो आगे की तरफ उनका आर्थिक और जो उनका सामाजिक विकास है वो संभव हो पाएगा। और उसमें भी ख़ास तौर से मैं इस बात पे आप लोगों को ध्यान दिलाना चाहूँगा कि उन्होंने जो लड़कियां हैं इन लोगों के बीच में, उनके ऊपर विशेष ध्यान दिया है, क्योंकि वो सबसे ज़्यादा वनरेबल ग्रुप है। तो ये एक अच्छा जानकारी रही हम लोगों के लिए। जो नेक्स्ट पैनलिस्ट इज डॉक्टर अशोक अग्रवाल, who is ILAP coordinator, and question for him is, what is the role of ILAP in supporting NLEP program? Ji.
Thank you, sir. Thanks for the opportunity to speak at the first ever National Leprosy Day observation. I think this is a big milestone which we have established today. We are a group of 9 international agencies, And this is particularly because there are some people who don't know about ILEP. And we started working in India from 2000. So since 2000, we have been active. The 9 agencies, if I list them out, IFO, FairMed, ALM, DFID, GLRA, LEPRA, NLR, and TLMT. What is the vision we work with? The vision, our vision is no leprosy. No leprosy, no stigma and discrimination, and no disability. And we work closely with Government of India at the national and in the states. Our motto is to provide technical support, whatever support is required, which is key, which is strategic. We plan that support along with government and implement it along with different stakeholders. The recent most technical support which has been provided is the 2 documents which have been released today, the National Strategic Plan and AMR guidelines. I think almost around 50 people of those experts which Dr. Rashmi was mentioning, they belong to the ILEP network. And many of them have put in good amount of time. And we are very much thankful to the Central Leprosy Division that they had invited formally WHO and ILEP to assist in development of the strategic plan, and which we see that it has seen light of the day under the leadership of Dr. Anil Kumar and Dr. Mandal. The other important recent work which ILEP has supported, my colleague from FairMed is sitting here, they did the background paper on mental health for integration with leprosy. We are present in 18 out of the 36 states and union territories. Our main ground force, which is a dedicated force, is of 14 consultants who are placed in different states, and they work under direct guidance of the Central Leprosy Division. Besides that, we also have consultants at CLD, particularly the data analyst, which is placed there, and she has been doing great job. We also have the cutting edge medical care centers. We have 43 hospitals and tertiary care centers. In 21-22 alone, just 1 year, we conducted 1,278 reconstructive surgeries. And we also have the Apex training centers and labs, like in the AMR guideline, which has been released today. Out of, I think, 7 centers, 2 centers, they are from ILEP. We also have a large MCR manufacturing capacity in the country, much more than the annual need. And we are also bringing innovation in that, like we now testing with computer-aided techniques for manufacturing shoes, which are as per the need of a particular individual. We are also very active on the research front. In just 1 year, we have published 28 papers in peer-reviewed journals. And in last 1 year, we have invested around 61 crores on leprosy work in the country. Thank you, sir.
Thank you, Dr. Ashok Agarwal. I think they have very important role. They plan with Central Leprosy Division. They talk to different stakeholders and they coordinate with everybody. They provide consultants supporting the program, and consultants are placed in different states. They have hospitals also, and they are doing research work also. I think their support is definitely, we must accept that this support is vital to implement National Leprosy Eradication Program very effectively in the country. And one thing, I would also like to say that on daily basis, we can, consult. We have somebody, we can always, call them and we can consult with them. One of the things, which we need to understand when we have to implement the program, then we need expertise, not only the academic expertise, not only the specialist in medical college, but also the expertise or specialization in the field implementation. That type of expertise or specialization we get from ILAB, which is very, very important for effective implementation of the program, and we must acknowledge that. Thank you for what you said. Our next speaker is Dr. Sanjay Pandey, GHAI. Sir, can you brief activities of GHAI and activities of GHI for leprosy patients, please?
Thank you so much, Chair, sir. And very good afternoon, everybody. The Global Health Advocacy Incubator is a part of the campaign for tobacco-free kids. And we are working in our country almost more than 20 years or so. And primarily we are actively engaged with the ministry and also with the Institute of National Importance. Through them we provide the technical assistance to the states. And those institutes of national importance are primarily AIMS, various AIMS, PGI and other institutions on that. And also, especially for the tobacco control program in the country, we bring the global best practices and other things as a technical assistance to the government, and we provide them those support what the government needed here, so that the government can be really one of the best program implementation can happen here. For example, India is the only country in the world which really have 85% on the cigarette, say, packets, the danger sign on that. So, which no other country have that, so that the tobacco consumption really goes down on this. Under the Global Health Advocacy Incubator, we are working more than 55 countries at present, and here we are primarily working with the non-communicable disease part of it, hypertension and cardiovascular health, because the mortality data very clearly indicates that the maximum deaths happening in that area, and that is one of the area where we should focus on. So early detection and this part of it. And also we are working in the food policy space, because our food habits have changed rapidly, and mostly we are consuming, and whether poor people or rich people, around 25 to 30% the ultra processed food, which have got the high fat, sugar and salt, and which really leads to all the diseases. So how can we really have the warning sign even on this food product, so that it warns that okay, it has got a high sugar, and especially among the children and all, the obesity and the early incidence which is happening and doing that, and government is taking proactive steps on these directions on this. So sir, with the leprosy, which is one of the very new area for us, but what we want to bring about is the convergence, the intra-departmental convergence which is required for that. Because the people affected with the leprosy, in our vulnerability mapping, when we were doing some work on the National Urban Health Mission, which was, I was a part of it. So we did in many cities, the vulnerability mapping. In the vulnerability mapping, the most vulnerable community in any city is the community of the people affected by leprosy. And by vulnerability I mean they are totally disempowered, nobody reaches to them, and if they want to reach to somebody, nobody hears to them. Okay, so they don't have access to water, access to really sanitation, access to health facility, nutrition, food, or anything which we call for it. So they are the most vulnerable population. How can we really bring through convergence, even within the health system, under the universal health coverage, the comprehensive health care, to start with, where the global health advocacy incubator is there. So at least there, non-communicable disease screening can happen timely, and they can be educated about it, and we bring them that, okay, these are the lifestyle which they can have this. So awareness about their better life on that. That is one part of it. The second part is the stigma and other part of it. So, and stigma has got a various forms. If Ravi Prakash ji was mentioning, if you go to each state, the stigma forms changes and the nature changes, and stigma is a one form of exploitation which really further disempower them. So how can we really address in a local way through the local partners and all those stigma and awareness, and how can they really be mainstream into that? That's the second part of it. The third part is that wherever I have gone to leprosy patients or the affected people's colony, each story is so moving and they really touch us. So how can those story, because they are very strong story of each leprosy person or each leprosy child and all, so how can they really, their stories can be captured, can be documented, and they can be heard in the policy making part of it, so that many of the policies and other things can be really included into that. And lastly, sir, as we are entering today, I see that the entire program is entering into a new phase of this, where the acceleration is required and acceleration is happening on that. So programmatically it is very well done, but how can it matches with the budget, and the budget advocacy can be there, so which requires that within the system itself we require to have the budget advocacy through the development partner with the system, so that the budget can be allocated in the more effective way, and also state spends the money, because it's not only the allocation. If you find that the leprosy resource utilization is also, some of the states have got a lower part of it. So how can we really push that? That can be utilized further on that. So these are some of the area where we will be working through our advocacy approaches to really make the program more effective on this. Thank you so much.
Thank you so much. I think you very beautifully described the activities of GHAI, and also your work on tobacco and other related problems. And I think this is going to be one outcome of today's event, that we are getting, the leprosy is getting a new partner, GHAI. They are not only going to support us in detecting or in screening the non-communicable disease among leprosy affected person, but as he mentioned, they are also going to support us in other NLEP activities. So I think this is a good outcome, and I think we should clap for him for this. So coming back to our first panelist, Dr. Paul Lin Chan. Now I would like to mention over here that Dr. Paul Lin Chan has very sympathetic view towards National Leprosy Eradication Program, because she is she's making a point at all the meetings which we have under National Leprosy Eradication Program at Central Leprosy Division level, and she is attending. Not only attending, but she is very positively she is contributing, and she is giving very quite critical input during the meeting. So thanks for that. Your next question is, can you share the details of coverage of World Health Organization WHO NTD network in India, and also what these NTD consultants, how they are contributing towards National Leprosy Eradication Program?
Thank you very much, and thank you, sir, for acknowledging me. I have to let you know that this is my second tour in India. In the early days of 2004-05, I helped India architect the HIV program for treatment, for care, support, the advocacy that went through it, the stigma discrimination. So I understand, and I understand very well. So many things are actually very common in terms of the advocacy, the need, the stigma discrimination, the repeal of discrimination laws, the HIV bill that was just passed last year. That took almost 2 decades of work, but it is possible. And maybe for leprosy, you can take a page from that too. So there are many things that we can learn from the other programs and how they have approached all the different ways to move policy, to do advocacy. It can be done. India is a great nation and is a G20 president, so it is possible. Everything is possible here. For WHO, we are committed to stand with India on the fight for NTD elimination. Today is NTD Day, and NTD is a heterogeneous group of 20 diseases ranging from leprosy, kala-azar, lymphatic filariasis, there's rabies, snake bite, scabies is also part of that. So it's very wide-ranging, and we work on all of this, and some of it also has outbreak potential as well. So, and as we move towards disease elimination for leprosy, we will have to be vigilant on being really actively looking for new cases, because we have to go to the last case, the last mile, and not only reaching it, but also finishing the journey. WHO has a network of officers across the states. We have traditionally the national polio surveillance programs, which covers 36 states, and their duties are eventually evolving, and they support somewhat also some campaigns. But we have a network of NTD officers in 10 states, which is 45 people strong. And like WHO centrally, we provide technical assistance to the states. We strengthen surveillance. We discuss the technical guidelines, some normative. We try to help the states move forward, not just only technically, but also at the implementation and the operations level. And basically trying to ensure that there's more convergence so that patients can get integrated service delivery. So programs get converged and delivery of services are more integrated, because at the end, it is the same health systems that we are working with. So whether you test the one person for LF, or you screen for LF, and then you screen at the same time for leprosy patches, maybe that place is also endemic for kala-azar, maybe the liver, maybe there's an enlargement of liver. And at the same time, we encourage that, that person is also screened for diabetes, hypertension, because nowadays you may actually get more than one disease per person. So it's just that we do not need to get the patient or the person to the health system every time for one disease. It's just a one sitting, a one window, one stop approach. That's what we are trying to support states to do. And hopefully we'll get there. We are committed again to leprosy, to NLEP, and to India to help really get eliminated disease elimination of NTDs, or the core NTDs, by 2030. Thank you.
Thank you very much for providing us this important information. Now, you mentioned about the NTD network. You also mentioned about the NPSP network. Now, I was just wondering whether we can think of in future the linking this NTD network and also the NPSP network, so that our network is widened and we get the program gets much more support from WHO. That is something we can think about in future. अगला जो प्रश्न है वो श्री रवि प्रकाश जी से है, और उनका प्रश्न ये है कि समर्पण फाउंडेशन ट्रस्ट के द्वारा कुष्ठ रोगियों के कल्याण के लिए अपनी गतिविधियों को बढ़ाने की क्या योजना है?
अभी वर्तमान में जो मेरे पास चल चिकित्सा की सुविधा है उसमें और बढ़ा के 1-2 गाड़ी और बढ़ा के उनमें शीघ्रता से पहुँच माने जो हमारा चेन चल रहा है उसको थोड़ा सा और फास्ट करने की आवश्यकता है। और चूँकि संपर्क का सबसे अच्छा माध्यम चिकित्सा है और समाज में परिवर्तन करने का सबसे अच्छा माध्यम शिक्षा है। समाज शिक्षित होगा तो वो तमाम सारी भ्रांतियां दूर हो जाएंगी जिसके लिए हम सब लोग इकट्ठा हैं। और तो ये हमारी योजना है कि हम ज़्यादा से ज़्यादा बच्चों को शिक्षित कर सकें, उनको रोजगार परक शिक्षा दिला के और उनको समाज की मुख्य धारा में हम कैसे जोड़ के ले आएं और उनके अंदर से जो वहम है उसको निकालें और कुष्ठ मुक्त भारत को के स्वप्न को साकार करें, ये हमारी योजना है।
जी धन्यवाद। मैं आपको ये भी और आपसे कहना चाहूँगा कि ये जो आप नोबल कार्य कर रहे हैं इसमें अपने आप को आप अकेले ना समझें। सेंट्रल लेप्रोसी डिवीज़न, नेशनल लेप्रोसी इरेडिकेशन प्रोग्राम और जो हमारे पार्टनर हैं WHO और ILAP पार्टनर हैं और जो हमारे अन्य पार्टनर हैं वो भी आपके साथ हैं। तो जब भी आपको आवश्यकता पड़े हमारे किसी भी स्तर पर हमारे सहयोग की तो आप हमें ज़रूर हमें बताएं और जो भी हो सकेगा हम आपको इस कार्य में सहयोग देंगे।
हम जो भी अब कार्य करेंगे वो सब NLEP के संज्ञान में करेंगे और सूचित करके करेंगे ताकि जो टीम में मैक्सिमम इन्हीं कुष्ठ रोग से प्रभावित रोगियों के संतानों की ही संख्या अधिक है। क्योंकि मेडिकल फैसिलिटी टीम में भी अधिकतर उन्हीं बच्चों को हम साथ में रखते हैं, क्योंकि वो उस समय कुछ ट्रेनिंग होते हैं, कुछ की ट्रेनिंग हो चुकी होती है, तो उनके भी अंदर एक अच्छा संस्कार या प्रभाव पड़े। अगर NLEP और आपका मंडल सर का और भी जो भी डॉक्टर्स लोग हम एक दूसरे से परिचित हो चुके हैं, अगर सबका इन्वॉल्वमेंट रहेगा तो हमें लगता है कि जो काम हमारा जो लक्ष्य अधिक दिनों का है वो कम समय में ही पूरा हो जाएगा।
जी बिल्कुल बिल्कुल। अब मैं दोबारा डॉक्टर अशोक अग्रवाल जी से I will again, I think I should switch to now English. Dr. Ashok Agrawal, he is not only ILAP coordinator, but he is also chief of the NLR, No Leprosy Remains. And his contribution, as NLR's contribution is also, is a significant contribution. And one of the contribution which I would like to mention is that NLR supported us in implementation of the LPAP, the post-exposure prophylaxis project at Dadar Nagar Haveli, on the basis of which the experience which we gained during the project, we implemented post-exposure prophylaxis, single dose rifampicin post-exposure prophylaxis in the country, first time in the world, even before WHO recommendation came, and that was in 2016. And now again they are working on PAP++. That project is undergoing in Uttar Pradesh, in 2 districts of Uttar Pradesh, and if we are able to achieve, we are able to implement it successfully, then probably it will be a game changer, because with current post-exposure prophylaxis, the protection level is about 60%, and we expect that with PAP++ it will be more than 90%. So Dr. Ashok Agrawal, second question is future plan of ILAP in NLEP and how ILAP will be supporting the acceleration of program activities laid down in roadmap.
Thank you sir, and thank you especially for recognizing the contribution of NLR as ILAP, and particularly on prevention, and that is going to be actually very, very important in the NSP. Like, as we know that for accelerating the implementation of NSP, which is interruption of transmission, and now we have a very ambitious target that we want to achieve in 2027 what many other countries would want to achieve by 2030. And so for that, we actually will need to move shoulder to shoulder, plan shoulder to shoulder, and leave nothing unturned, no stone unturned, which means that we should unite ourselves. First, we should understand the NSP roadmap thoroughly. So for that, sir, what we are thinking is that we'll have a special orientation of our ground force. Ground force meaning force of 14 NLP consultants. They need to be totally oriented on it. Like everyone has contributed, but then the final product needs to be learnt by them thoroughly. And then they are going to be the mentors for the state leprosy programs, right? And which is very important. And they not only affect the program at the state level, but at the district and sub-district levels. And that is where we will bring this acceleration. And acceleration in all aspects, which is like in early case detection, in treatment, early detection of reactions and treatment, disability care, prevention. We know there is a lot of avenue still to be addressed. Like we know in training, sir, like we know that there is a big backlog of training. I'm happy to share that iLab globally, they are bringing in 2 important projects in India. One is called LIFT, which is going to be specially targeting at capacity building with modern tools and modern methodology. So that project is expected to be starting this year. And there is one more project which should soon see the light of the day, is using GIS mapping for selecting hotspots, and hotspots for early case identification and applying all our strategies there. So these 2 projects are in the pipeline, besides what the ground force which we have and the consultants which we have. We'll keep on supporting that. And also, as we are now working towards bringing in new technologies meaning innovations for early case detection, and for which we are our agencies, we are working towards mobilizing resources for doing pilots. How do we, and multiple kind of pilots. We are also thinking of doing a study on blanket approach of prevention. Sir has already mentioned about PEP++, which is going to be very, very important. And I'm again very happy to share that though in India we started implementing, meaning administering the drugs of PEP++ only this year, but we are competing very well with other countries who have started earlier because of the full support which we have got from the Central Leprosy Division and the state government. We are also, sir, as we have seen during this year, that we are making progress on mental health. So that's going to be our important portfolio of work. And I should also mention the work which is being led by Nikita, which is on stigma discrimination, right? So that's very, very important. And Ravi Prakash ji has mentioned about that. And I'm very happy that Dr. Sanjay Pandey, who is joining this group today, but you have indicated one very important thing, that you did vulnerability mapping, right? And the most vulnerable group was leprosy affected. This should go out widely in the audience, right? This decision makers will be moved by that. And you said that that will move for the budgetary allocation, which is very, very important, right? So, so these are the words I wanted to say, that we will continue providing the support, the little support which we bring in, programmatically, technically, research, etc. Thank you, sir.
Thank you for sharing the information. So I think all these are very important areas where we need to work. So my last question is to Dr. Sanjay Pandey. He already agreed to support National Leprosy Eradication Program and Central Leprosy Division. So your question is how you are going to support. So your future commitment. So how does GHI plan to engage themselves for NLEP? So we need to know your roadmap, and we want your engagement immediately with NLEP.
Yeah, thank you so much. So the commitment is there, and we as a team, we have a very small team here. So we are providing and working very closely with Dr. Mandal in his team on that. So we will start with that, and whatever resources which we have, and wherever the tools and other things which we have, we will share immediately into that. So that's one thing we will start with. And wherever we are working in the 3 states, especially, we are collecting some of the patients' voices through the aims and all. So we will make sure that we also go to the leprosy colony and all, and we collect those cases in those format and share with you and get your input how it can be further defined for your purpose and all. So we will definitely do on those work on this. And for the we will come out with some module for integration, the intra-convergence, what we talk about. So when anybody who goes to the health wellness center, so for anything, as you were saying, how can the entire thing can be really looked into? So at least the blood pressure measurement can happen, the diabetes can be checked up there, and follow-up can be there on that. And we will work out with those things and come out with those roadmaps and all. Yeah.
So the conclusion is that Dr. Sudarshan Mandal is going to get good support from all the partners, and I think I must congratulate him for getting support from everybody. And I think it was a good discussion during this panel, and Dr. Mandal designed this panel discussion to make it very useful. So thank you, Dr. Mandal. Thank you. Thank you very much. Thank you. Thank you all the panelists.
Thank you, sir. Dr. Anil Kumarji, who chaired the session, role of development partners in National Leprosy Eradication Program. So I would now like to invite please, sir. I'm right.
So we should take some questions from the audience. I mean,
also,
for the panelists and also chairpersons.
Okay.
So sure. I have let me go first. I mean, so I have one question. I mean, for Global Health Advocacy Incubator, GHAI, Dr. Pandey, that you are working on tobacco and also non-communicable diseases, particularly tobacco and non-communicable disease. So you know that I think the demarcation between the communicable disease and non-communicable disease has been almost diminished. I mean, you can know the Kaposi sarcoma of AIDS, HIV patient, grade 2 disability of leprosy patients. So why don't you work, I mean, think about the grade 2 disability patients to facilitate their reconstructive surgery and other things? Or not only, I mean, that leprosy patients and our grade 2 disability patients, they can also suffer from many various, medical illness or ailments. So we can give support also regarding that other diseases they suffer. Apart from that, vulnerability mapping and everything. And you have a component in your program, I know, that you always, there is a policy advocacy to increase the amount of budget for any program, not only for leprosy program, but also TB program and other program also. So why don't you start that advocacy, political advocacy in our country, India? So I want to hear some, few words from you.
Thank you so much. As I'm just a newborn here, so I will definitely like to have more understanding to really come out with that plan. But definitely, like as you just said, because we see that our political leadership, they also need lot of sensitization and continued engagement. because that really helps you a lot on that. So we can definitely come out with certain those plans so that it can be there. And also for the budget advocacy, the budget analysis, and why we need it, and how it can be there and all, so that we really get those budget part of it. So we will use those tools also. And some of the tools which we have, we may customize for the leprosy program, so that the leprosy program and the purpose can be really highlighted, so that it is in line with your strategic document, and it can really communicate that purpose very well to the policymaker. So yes, as a newborn, I commit that, and with my larger team, with the global team and all, we would definitely like to be a part of your partner. Yeah.
Thank you very much.
So and any other question? Yeah.
Dr. Manos.
Sir, I think this the role of development partners and the discussion what we had is very, very interesting, and actually we learned a lot of things from the panelists. And sir, actually from Dr. Pauline Chan Madam had touched upon the convergence of the various services in the context of leprosy care for the persons of the affected by the leprosy. But what I feel, there are many programs. Definitely, in the many areas we need a convergence. But one of the important, most important programs where we need much convergence is the disability care, because already there are many areas, like in lymphatic filariasis also there is a MMDP, morbidity management and the disability prevention. Apart from this, there are other disability services for the other general public. So, and normally if you see, the integration has happened in 2005, and it started with the modified leprosy elimination campaign. Actually, that integration also started with a campaign mode, and then there are a lot of services was being, a lot of initiatives been taken, and a lot of campaigns are also being made. So we need also a campaign, a movement for the disability care also, unless and until, because ultimately it is linked with the stigma and discrimination. So if we can have a robust program of the DPMR or whatever we can, maybe in a convergence form at the mass level, I mean especially I am talking about in the general healthcare level, unless and until we do that, we will not be able to cover the so many populations, persons with affected with the, if you cumulate the total number of disabled persons affected by leprosy, it is huge. I mean, they need a lot of services. Even today, most of the disability persons are going to the specialized institutes only. Hardly few people with the ulcers and badly deformed ulcer patients go to the primary health system and get the service. So this is the another development partners can play a big role in converging these into the general healthcare systems to give the wide support for the persons affected with the leprosy. Thank you.
Thank you. Thank you for bringing that out. Yes, I did mention disability. In WHO, the disability and prevention program is up and coming. In fact, there is also a lot of movement at the region and also at the global level on disability, as well as assistive technology. I think Dr. Anil, you were also part of that group. The realization is that convergence, where they can converge for physical disability and deformity, is between LF programming and also leprosy. But they are not quite the same. They have some different needs. However, India has a very big manufacturing base. There's a lot of innovation opportunity, is a hub where India, like drugs, could manufacture the assistive technology for the world. So these things are all in discussions at the moment, but what we could start off with is really a real look into disability itself and where the continuum of need is, because today if a person affected by leprosy at 24 years old may need something else, but when the person is like 45 or 60 years old, it's different. And that could also, just of a food for thought, the aging, the age of our society also needs some form of assistive technology. I'm not talking about crutches and wheelchairs. I'm talking about sometimes And I see increasingly, even my landlady, Indian landlady downstairs, she cannot turn a bottle because of arthritis of the hands. So these things are all belonging into the realm of assistive technologies, where I'm not an expert, but certainly an area that is underinvested, or we haven't really looked into it yet. And this is an area that we can explore moving forward. Thank you. Thank you for the point.
Dr. Manas, there are three things in this, the question which you asked. First of all, why, ulcer, person with ulcer is going to, hospital. That is, I think, issue with the program. We are not able to, manage that properly. We are not able to strengthen primary health center to take care of those, ulcer and all that. And we are not able to provide services, DPMR services very effectively. Otherwise, that will not happen. Even our CLTI Chengalpattu, somebody is coming who could have been treated at primary health center level. So we need to strengthen that thing. Second is specialized services. Now the RLTRI and CLTRI, they are expected in this change scenario, they are expected to provide specialized care, the mental health care, specialized mental health care for leprosy affected person, specialized, the vision care at the Central Leprosy Institute. That type of institute we should have developed. There are many other tertiary care institute, not only CLTI, RLTI, but state government, they are also having. So we need to develop them as a specialized, care that we are not developing. Third is the assistive technology. Now it's a good development. Niti Aayog is bringing all the partners, all ministries, all different partners together to develop this assistive technology. And we want to India there is a plan that we will be hub for assistive technology in the world. And we need to develop those assistive technology at primary health care level, also secondary level also. So if we are able to do that, that will solve a lot of problem. So I think my time is.
Just one point. I mean, regarding discrimination and stigma, we always, point towards the leprosy patient and their families, their social contacts. Why don't we discuss about the healthcare providers? Many of the healthcare providers, they are stigmatized actually. I mean, I know many of my friends during the MBBS days, even during the MD days, they suffer from tuberculosis. I mean, not leprosy, but tuberculosis. But they strictly, told to the, close circle, their peer groups, that don't reveal my status, disease status. So they are all doctors, even some of the postgraduate doctors, they don't want to reveal their disease status. So I think we have to eliminate or eradicate stigma discussion from the minds of the healthcare providers. I mean, I have seen throughout my, I have a rich experience, long experience of service, though in the Central Health Service, but I think we are stigmatized. The healthcare provider are the health manager are stigmatized. They are stigmatized. And Ravi Prakash ji, आपने बहुत अच्छा बोला, आपने जो बोला आपने लेप्रोसी पेशेंट के साथ बैठ के खाना खाते हो, उसका साथ बात करते हो, और मेरे को पता है जो फॉर ए just limited exposure, maybe 1-2 hour exposure can't cause leprosy. It requires a long exposure, long prolonged exposure to have leprosy from any person. So आपका इतना scientific mind है, आप उसका साथ खाना खाते हो. Why not the doctors, nurses and other people? I think healthcare provider is stigmatized. Though it is, it looks odd to mention that in this forum, but I know, this is my personal perception actually, and that I want to, throw in this forum, in the important discussions.
Sir,
please.
Yes, to the WHO, I just want to ask one question. Is there any specific, like in filariasis, other things, we are having a validation tool and a validation document. Is there any specific validation now for leprosy is already there, some document that in another 2-3 years, because already now 68 districts are in the low priority as per NSP. So these districts will now start to ask for subnational certification or something for elimination. So we need a document for validation of it. So that document also should be in course of time, should be ready by we have 2027. That is the first point I just want to ask. Second thing is, as madam has said regarding our change in population, I think that's a very good point because as per CBHI document recently released, Tamil Nadu is going to be the first state, not far away, 2030 to 35 is going to be the first state to go into negative growth of population. So this is so near. So automatically our demography is going to change. We are going to get a lot of elderly people, and that comes to his point where we have to integrate a lot of programs together. Because I don't know, because we are working in silos. Like in the palliative care, there is a physiotherapist who goes house to house to do a lot of wound dressings, to do a lot of colostomies, everything. So these people also can be utilized in our program. In the geriatric care, there is another nurse who goes home, house to house. She does a lot of work with the geriatric people, does physiotherapy and all those things. So these types of, so many programs are going on which we can integrate into our system so that in future it has to be an integrated approach.
With the permission of chair, can I?
Just very quickly, thank you very much, and excellent points here. We currently in WHO don't have a guideline or criteria, but I'm sure at the global level we will be discussing and working on it. Also, the transmission strategy was quite new, so we'll have to help learn also the experience of countries, how we move this forward as well. Thank you.
And my comment is, why ask WHO to develop that document? Let us develop document, and we take WHO with us, and that document can be used anywhere.
Sir, I was
by
actually,
WHO.
I was
So
part of the validation for malaria.
No,
That's why I asked.
No, I think in leprosy, we need to be leader.
Yes.
And based on our experience, WHO should support other countries. This is what I feel. So
Sir, last question.
So I think it's already time is over. So okay,
Small.
quick.
With permission of chair, sir.
Quick.
I heard Dr. Sanjay Pandey also and Chan madam and the distinguished faculties here. I would like to mention, Pandey sir, that you have done a vulnerability mapping, and I would suggest that if it permits to you for mapping of the utilization of the health facilities by the leprosy patients, how our the leprosy patients are been received or treated at the various health facilities, right from district hospitals to the medical colleges. That will give you us a thing. And number two, you said the support for the nutrition. You talked about the vulnerability population. So that comes to the point that our children are suffering more for the presenting with the related to disabilities, and the nutrition supplement as it is provided in TB control program should have been introduced in the NLP programs.
Okay, and you also ask.
Yeah, just a very quick one, and it's wonderful, Dr. Sanjay, you're part of this. And I just wanted to say one more thing, that we should normalize eating food with people affected by leprosy. When we are doing capacity building, we are sleeping in the same room. So I've never thought till this moment कि बहुत बड़ी बात है. Secondly, when I am when you were talking, leprosy is a very complex issue because there are some people who come from the vulnerable sections of society who have leprosy and disability. But there are a lot of people that I meet, like I recently met a person who's a major general in the army who has leprosy. There are people who are working with Google, and there are many more. So, and people who are working only within colonies are having only low-hanging fruit. I would request you to expand your area of operation, because in the last 20 years, no new cases of leprosy have been in leprosy colonies. All the 1,14,000 cases are from the general community. So, and they have a huge amount of different set of problems. So I'll be really happy to,
Okay.
take this forward and address
Okay.
it.
So just brief reply in 1 or 2 seconds. Okay. So no reply required. Okay. Thank you. Thank you very much.
Thank
you
so
all the
much.
panelists. Thank you.
I would, ma'am, sir, please stay with us on stage for a few moments. I would like to invite our DDG sir to please felicitate chair of the discussion, Dr. Anil Kumarji, Additional Director General of Health Services. So Dr. Sudarshan Mandalji is now felicitating, a gesture of thanks to Dr. Anil Kumarji. May I request Dr. Lily Gangmai ji to please come onto the stage. Dr. Lily Gangmai ji will felicitate Dr. Polin Chan, WHO. I request Dr. Shweta Singh to please come onto the dais and felicitate Shri Ravi Prakash ji from Samarpan Foundation Trust. I request Dr. Gavish to come onto the dais. Dr. Gavish, yeah, please. Please present a memento to Dr. Ashok Agarwal ji from International Federation of Anti-Leprosy Associations. I'm requesting Ms. Richa Bharti to please come onto the stage. Richa ji, please. Please felicitate Dr. Sanjay Pandey ji from Global Health Advocacy Incubator. So with this, we would like to thank our chair and all the panelists. Thank you so much, ladies and gentlemen. Thank you. And now we move on to our last session, that is technical session. We have best practices and success stories of leprosy elimination in the country. May I invite on stage to chair this session Shri Rajiv Majhi sir, Joint Secretary Leprosy, Ministry of Health and Family Welfare, Government of India. Shri Rajiv Majhi sir. I'm also requesting Deputy Director General Dr. Sudarshan Mandalji to please join us on stage. May I humbly request Dr. Rashmi Shukla ji, National Professional Officer, WHO. Ma'am will give us insight on global best practices. I also request Dr. Lily Gangmai ji, Chief Medical Officer, to kindly come onto the stage, and ma'am will throw some light on best practices under NLEP in India. Yeah. So this is the last and final session of the day. It's over to you, sir. Thank you.
Good afternoon, everybody. This session reminds me of, one very popular anecdote. There was a preacher and he was preaching the people. After some time, all people have moved except the one person. He was still encouraged to speak, saying that at least one person was hearing. On conclusion, he asked the gentleman that, yes, I'm happy, at least you are listening me. He says, sir, I'm the 10th man. I have no option but to sit here till you finish. So now the situation is like that. those who have some, some connection in one way, some program people or some people, they may be here. So I was suggesting our DDG that why can't we conclude now? How are we going to achieve anything by this session? Or what shall we communicate which these people don't know? So these things we need to ensure that though the strength was 100 or 150, so we failed on that account to ensure that 150 people remain here till the end of the program. So this also reflects upon our failure. So we are here to celebrate our failure before you, those few of you are here. So maybe in 10 minutes we'll finish, okay? Thank you. Yes.
Hello. I think this session has been fixed to give some views regarding the best practices available in the global scenario and also in India. I think the global scenario, NPO, National Professional Officer of WHO, Dr. Rosmi can, throw some light on global scenario, and if you have any presentation or anything else, or yeah. You have presentation.
When I was, good afternoon, sir. JS has very rightly said that we have a few very dedicated people still staying back to listen to us. But I think we should not be disheartened because many of our own colleagues are celebrating World Leprosy Day and National Leprosy Day in their own organizations. So perhaps one of the reasons why they are not here. Now, on the topic that was given to me, best practices from around the world, I have to state here that I went through so many documents, so many research papers, but I came across very few best practices which are being implemented in the programmatic mode in different countries, which India is not doing. So here I would say that India should be really proud that most of the good practices across the world are already in practice in this country. Because perhaps we have such a large burden of the disease in the country, we may be still held responsible for having too much of leprosy in the country, but then we have such a large population, and one of the reasons why we are at the top of the list. So can we have the next slide, please? So here I have just tried to put together some of the points which came as something new. Otherwise, most of the best practices are only in the form of this is a beneficial activity if a program incorporates it. But there is no country that is incorporating it. So here I came across the most common one was contact surveys, the best practices on different ways to reach out to the contacts of patients to interrupt the transmission. Many countries had skin camps. In India, we had done away with skin camps a long time ago. There are very few states now that actually organize skin camps. Skin camps was part of the Indian program a few years ago, but then because these skin camps led to a lot of overdiagnosis, or we did not have treatment for those people who had other skin ailments. So this was discontinued within the program. Then a good one that came across was self-help groups detecting cases. This came across as a new practice, but then Jharkhand this year has already engaged persons affected by leprosy in the new case detection activity that they had in Devghar district. So self-help groups can be part of new case detection. This is one practice perhaps which India could include. There were lots of mention of school children education programs, mainly in Brazil, They gave away pictures of self-image, an outline of the body, and the children are asked to identify signs and symptoms of leprosy in their families, and then come back and report to the school teacher who has patches on their body or who has any of the other symptoms of leprosy. Next, please. The other factor which I saw that was really impressive was that in many countries the partners have been given total responsibility of parts of the country. Like in Sri Lanka and Bangladesh, like in Sri Lanka, the dermatologists are totally involved in the program. Like we discussed that in India, we are still not having all the dermatologists engaged in the program. But in Sri Lanka, dermatologists throughout the island play an active role in diagnosis, treatment, management of reactions, and they are arranging even rehabilitation, and they are doing the documentation and sharing it with the government. In Bangladesh also, for many years, they had nearly 70% of the country under the support of NGOs. Next, please. Integration with different programs. This is one of the best practices that are really there in most of the papers. Even in the International Leprosy Congress that happened last year in November. So Brazil formulated a national plan to fight and eliminate or control 6 diseases that affect populations that live in poverty and lack full access to the country's health services. So these were leprosy, lymphatic filariasis, schistosomiasis, onchocerciasis, trachoma blindness, and STHs, that is soil transmitted helminths. So the integrated campaign was this was an intersectoral effort aimed at significantly reducing the number of people, and this was mainly done with the idea of reducing poverty in the vulnerable just because they were suffering from these diseases. So the spearhead of the campaign involved educating children about the symptoms of leprosy and then detect them in order to enable them to detect cases within the children, or these children go and recognize the disease in the community, in their family, and they become the messengers for case detection. Next, please. The activity, so this activity was done by educating the teachers, the parents, and the students, and the Ministry of Health took advantage of the opportunity to conduct other interventions. So when they were conducting these interventions, they even had the deworming program going on. So these are some of the citations that I saw in the research papers. And an additional benefit of the campaign was that many of the children who participated in the program, they were, imparting the knowledge to the siblings, and then this was a chain reaction, and the siblings in turn went back to their own school, and then they started spreading the message of leprosy. Next, please. This was a very beautiful example I saw, because we always talk of management and prevention of impairments and deformities and plantar ulcers. But there was this mention, lifestyle modification. Behavioral change and lifestyle modification. This is something which, when we counsel a patient, take care of your hands, don't do this, don't do that. But then when we if we do not have a good understanding of how the person works during the entire day, we will not be able to give the right advice. If we say you have ulcers in your feet and you should rest, that is not going to help, because if the person has to work, he will anyway go to work. So lifestyle modification came up as a new idea to me, and I think this is something we can bring into our program and try to kind of define for any person who is into any kind of occupation or the kind of lifestyle, how they are going to modify the way they operate, the way they hold things, the way they walk, the way they carry things, that will be beneficial to them, and it will prevent disabilities and worsening of disabilities mainly. Next, please. Another important thing that came up was leprosy in pregnancy. This is something that we have not taken much, we have not paid much attention to, and that says that special attention needs to be given to women during their pregnancy. So this is another cross-cutting area with the maternal and child health program. And because in leprosy we give steroids for long duration of time, in pregnant women there is great chance of lepra reaction, and then for lepra reaction she needs steroids. So all that needs to be really taken care of, and we have not looked into this aspect of the problem in our country. So this came up as a new best practice which should be part of our program. Next please. The other thing was artificial intelligence. Nowadays there are a lot of ambitious plans. There are already several devices on taking a scan of the skin patch, and then the artificial intelligence mechanism tells us whether it is leprosy or not. So all these have not been part of the program in any of the countries. They are still in the research mode, still in the development mode, but not in the programmatic mode. Next please. India is having a lot of problem trying to decide whether leprosy should be made notifiable or not. But I was surprised to see that Brazil had already made it a notifiable disease in 1980. And they continue to keep it as a notifiable disease. So this was just, I thought I'll mention it here, that there are countries that have made it notifiable. Next, I came across this mechanism of finding hotspots. I think this is a very useful tool which India could use. In this, to identify hotspots, spatial scan statistics was used. Now this is very technical from the statistics point of view, so I wouldn't be the best person to put it across to you. But there was this mechanism of a circular window which moves through a map with its center at the coordinates of the health facilities, you can call them. Here it says municipal councils, and wherever this window moves, it makes an assessment of within a radius of 500 kilometers how many patients are there. And this is some model in which, with that information, how many people live in that area and how many patients there have been over the last few years, there is a prediction of how many patients are expected to be found in that area, and which are the areas which are hotspots. So this was a study in Brazil, and they found that within the 21 degrees south and 4 degrees north latitude, most of the hotspots were there. Next please. For training, there was this model which said that 70% of the learning comes from experience, experiment and reflection, and 20% from working with others, and 10% from formal education. So this entire study, I was surprised to see that India is also part of it. The countries that have shown interest in piloting this framework are India, Brazil, DR Congo, Bangladesh, Nigeria, Nepal and Mozambique. And here they are trying to develop materials, methods and tools which will tap more of the 70%. How to give people the 70% learning which comes only from experience and reflection. And in our program, mainly we focus on formal education, and that is only 10%. Next please. There was a mention of a leprosy-friendly village model in Indonesia. They developed a leprosy-friendly village model. In these villages, healthcare workers and community members are sensitized to leprosy's early symptoms and stimulate and timely patient referral. So this is something very close to what we have in the hard to reach areas and special plan districts. So in this, the community members are given some education and they become kind of a part-time ASHA. And they refer the suspects whenever they come across them. Next, please. Then there is mention of this suspicious symptom monitoring. This was already part of the Indian program several decades ago, and there was a suspect register which used to be maintained at the PHCs. I don't know, perhaps Nikita would remember, and some of the other people may remember that we used to have a suspect register. So all the doubtful signs and symptoms were kept on a suspect register, and they were monitored over and over again, and if they come up with leprosy, they are put under treatment. So this was an example from China. Next, please. So these are just points for thought. I thought I'll just share with you. We need to keep leprosy in focus and maintain awareness of the disease as a global health issue. We should not consider it only as a disease in pockets, because a communicable disease always can move from one part of the country to the other, or from one country to the other. Eliminating leprosy demands effective case detection models for hard to reach communities, and where untreated patients continue to spread the infection without knowing it. And we need to continue to bring technical and scientific innovation. This is the need. We have to find people with whoever has any of the newer diagnostic tools or vaccines. As soon as we find that they are effective and imbibed in the program, we can make greater progress, and artificial intelligence and digital technologies. Next, please. So innovative strategies that interrupt transmission, such as post-exposure prophylaxis, better regimens of post-exposure prophylaxis, this is all that we can look forward to, and continue to develop new ways for all the stakeholders. I think we have already started. And only on maintaining an extraordinary level of collaboration, we will be able to address global health challenge. And I think it's still work in progress, though we are looking at the finishing line, but I realize in terms of best practices, it's still a lot of work in progress. Thank you so much.
Thank you very much. Dr. Lily, it's your turn. You have to depict the picture scenario of India. Yes, sir. Hello. So, Dr. Lily, you start your presentation.
Hello. Good afternoon, everyone. Good afternoon, Chair, and Dr. Mandal and Dr. Rashmi also. And good afternoon. My presentation is best practices under NLP in India. Today we have almost come to the end of the program, and everything has been said and done. It is just a repetition of the previous presentations. However, I would like to bring focus on the different steps, intervention which has been taken under NLP in India. Next slide, please. I can't see. I'll have to look here. In the initiative introduced under NLP in the last 6 years, in first case, this is early case detection. Here, leprosy case detection campaign LCDC for 14 days in high endemic states. Here we take a house-to-house visit by team encompassing one ASHA and a male worker as per microplan. Number 2, each and every member of the targeted population was examined by the search team. And the second is ASA-based surveillance for the leprosy. Hello? Can you hear? Hello?
Yes. It's audible, please speak.
ASHA-based, I think it's audible. ASHA-based surveillance for leprosy suspect absules. This is an active surveillance. This conduct active surveillance in the leprosy suspects, including nil report every month. Number 2, improve monitoring and supervision of the leprosy case detection activities at the level, village level. Next is focus leprosy campaign in low endemic states. Next is special plans for the hard to reach areas. Next slide, please. Under prevention, it's for the first time in the world, leprosy post-exposure prophylaxis by administration of the single dose of rifampicin to the eligible contacts of the index case in order to interrupt the chain of transmission. Next is monitoring and supervision. Under this launch of the revamped NICUS 2.0 in 2000, today we have launched this. Joint monitoring and the investigation group visit to states and UT to be started this year. And grade 2 disability epidemiological investigations, directory of the leprosy experts to support the program implementation, and provision for certification and award for the district in the following categories, and the categories are silver category and gold category. Next is IEC and training. Under IEC we have sparse leprosy awareness campaign, SLAC, which is happening every year. Next is national level training of SLO, faculty of leprosy institutes and WHO consultants, etc. Next slide, please. And under the convergence of leprosy screening, under screening comprehensive primary healthcare under Ayushman Bharat through community-based assessment checklist, Rashtriya Bal Swasthya Karyagram, Rashtriya Kishore Swasthya Karyagram, and disability prevention and medical rehabilitation. We have reaction management, provision of MCR footwear, aids and appliance for disabilities and deformity, self-care counseling services, and provision for self-care kits, referral services for management of cases, reconstructive surgery at district hospitals and medical college, central leprosy institutes, and a welfare allowance of rupees 12,000 to the leprosy affected person who undergo RCH. And the treatment of leprosy is provided free of cost in all the government health facilities across the country. Next slide, please. This is one of the indicators which we have chosen because of the intervention, the various intervention which has been presented earlier. Because of that, it has impacted the level of the indicator which we have taken, grade 2 disability. In 2016 and 19, it was 4.61. And now it has come down to 2.47. Next slide, please. Sparse Leprosy Awareness Campaign. Sparse Leprosy Campaign, SLAC, conducted across the country on Anti-Leprosy Day, 30th January each year. Now, we theme for the 2023, let's fight leprosy and make leprosy a history. Next slide, please. Now we have come to the best practices from the state's perspective. We have chosen some states. Next slide. We have chosen Maharashtra. Maharashtra, they have, these are features which they have adopted. And number 1 is survey of the villages with 0 leprosy case during the last 5 years. They have action plan prepared by all the district to verify actual status of the leprosy in this village. Special survey done by NMA, PMW and MPW. Supervision done by NMS, BMO, district level and state level officers. And they have Maharashtra has done GIS tagging also. GIS tagging of leprosy cases with the help of National Institute of Public Health Training and Research, Mumbai. The GIS tagging is very helpful in rational allocation of the resources, including manpower, planning, implementation, monitoring and supervision of zero leprosy transmission by 2027. Monthly review of the NMA, PMW and MPW. Next slide, please. Next, we have taken the states of Orissa. They have LCDC awarded as best LCDC performing state. Number 2, reconstructive surgery. They have integrated RCS activities in all the general healthcare system. All the district headquarter hospitals to perform reconstructive surgery for the benefit of the patients in their home district for better motivation. 1 IUS and MBBS medical doctor officer of each CHC, 1 health worker and one health worker male of each block trained and declared as leprosy nodal officer and block nodal leprosy worker respectively. Medical college have been integrated under NLEP with the supply of MDT and the patient cards. NLEP drugs integrated with the E-Niramaya. Next, Monday of each week declared as a leprosy day for all the NLEP activities. Next is the telecommunication with the specialists, E-Sanjeevani platform for diagnosis and management of leprosy cases. Next slide, please. Next, we have taken up Jharkhand. Jharkhand has done GIS mapping and village-wise data collection of all the leprosy, including disability case has been done. Next is digitalization of the reporting system. Under this, they have done online monthly progress reporting system, complete human resource detail with their contact number up to CHC level, monthly financial reporting system with auto-generated state, government and FMR wise report. Next is campaign micro-planning and monitoring. Next, all guidelines of NLEP available online in the same platform for easy accessible for the district and CHC at any time. Next is leprosy case detection campaign organized actively as per NLEP guidelines. Next, please. Next, we have taken up Dadar and Nagar Haveli. They have taken up active case detection survey. Under this, they have done general health staff by general health staff every quarter. Next, active search for suspect in evening hours.
Be fast, just fast.
Skin smear of all the cases. Next is contact tracing for all the new cases, PB and MB. Maintaining contact tracing register at all the sub-centers. Next, increased number of contact for PEP from 20 to 50 or more depending on contact availability. Next, for focus awareness initiative, evening community meeting at selected villages by district team such as ACSM officer, NMS and PMW along with the local health staff. Utilizing IEC opportunity at VHNDs and weekly hard bazaar in the village. Next is GIS mapping of new and old case. Next, hemoglobin estimation of all the new leprosy case and iron folic supplement to enemy.
Dr. Lily, I think we don't have enough time to
Sir, I finished. I've just completed.
for this session. Please, can you conclude within 1 minute?
Finish, sir.
Finish, okay.
This is the last slide. Finish. Thank you.
Where is the thank you slide? So we got the thank you slide. Thank you very much, Dr. Lily. You can take your seat.
Thank you. Thank you, sir.
So, sir, it's
Thank
over
you
to
for
you.
patient hearing.
And I must thank both the speaker
I mean, the first speaker, Dr. Rosmi, NPO, WHO, has elaborated on the global, I mean, best practices, whatever there, I mean, in some of the countries apart from India. And India's best practices was narrated and depicted by Dr. Lily, CMO, leprosy, of the Central Leprosy Divisions. So I think regarding that global best practices, whatever depicted by Dr. Rosmi, that I liked some of the, I mean, initiatives like self-help group. Self-help group is there in India, I mean, in most of the states, and at the village level they have self-help groups. There are women's group also. I mean, we can engage. I mean, I talked, I mean, discussed in my presentation also, why should not we engage those, I mean, all the stakeholders, including self-help groups, because they are working at the village level, most of the self-help groups, and they know each other and they know the people surrounding them. So why don't you engage them for the, not only for case detection, for also continuation of treatment, and also to support the leprosy patients, I mean, if there is any adverse effect of the leprosy patient, and also to support the grade 2 disability. I mean, to connect those cases, I mean, not only leprosy cases, grade 2 disability patients also, to the government health facility properly, so that they can get proper care and support from the government health facilities and other health facilities which are supported by our development partners. So that is a good idea. Another is self-examination. I mean, we know that self-examination of breast for women, and it's good because, you know, particular for the women, I mean, female patient, it's very difficult to examine from head to toe. We need one, I mean, female partner in the group. I mean, like, you know, ASA and another male partner for that LCDC campaign, leprosy case detection campaign also. So why not they, I mean, the person can examine himself or herself, and if they I mean, find any such kind of hypopigmented patch or reddish patch or any type of thickening of peripheral nerves, they can report to the most peripheral health worker like ASA and ANM, and also they can report to the healthcare provider of the health and wellness center, and also our primary health centers. And it's a very good concept, Dr. Rosmi. Self-examination of the common citizens, I mean, who may be suspected case of leprosy. Then another one, I think, artificial intelligence. It's a very hot, I mean, topic now. The artificial intelligence, I mean, we try to introduce everywhere the artificial intelligence in any program like TV and another program also. But I mean, we have not started yet the lab examination of leprosy. And only we are doing for the difficult case. So in that case, I mean, for case detection we can start. I mean, so we have to develop such kind of model, or I mean, we have to develop such kind of model. We have to take the help or support from the development partners how to develop such kind of model to detect the case early through a skin lesion. I mean, in that case, that can be possible later on. Another thing is, she has mentioned that Brazil leprosy had been, I mean, leprosy was declared as a notifiable disease in 1980, I think. And in our country, we could not, I mean, do that. We could not declare leprosy as a notifiable disease. The file is still moving, but certainly I think I have the, I mean, idea that we somehow in near future we can declare leprosy as a notifiable disease. I mean, I have discussed also in my presentation that I mean, it has, I mean, leprosy should be a notifiable disease to connect the private practitioner, the dermatologist, and all the private health facilities, so that they can notify disease mandatorily to the I mean, in the portal or to the government health facilities, so that patients which are being seen and cared by the private sector get proper support and proper drug regimen for leprosy. And regarding Dr. Lily's presentation, I think it's good that she has spoken about that single dose regimen, and all those things were depicted in the earlier presentation also. Hotspot very important. I mean, Dr. Rosmi has spoken about hotspot. I think in we also consider a grade 2 disability case, a single grade 2 disability case in urban or rural area, for particular the low endemic states and moderately endemic state. Whenever we find a single grade 2 disability case, we usually examine our most peripheral healthcare provider. They examine all the people of the village. In case of rural area, whole villages, people of whole village get screened for leprosy cases, and also in urban area, I think the surrounding 300 households, they screen actually to find out whether there is any such case, there is any suspect for leprosy. So all these, I mean, good presentation. Thank you both the speakers for a nice presentation and detailed presentation on good practices. Over to Joint Secretary, Leprosy.
So, sir, thank you so much, sir. I'll request Dr. Anji Chauhan to actually felicitate. Sir, please. Okay, please, sir, please. Yeah, sure.
Thank you very much. We have come to the end of the session. And tell me, anybody of you, have you got anything new with respect to leprosy? Anybody? What is new, madam?
Use mic, please use mic.
Yes.
You can take one mic from here.
Yes. What is new and how we are going to achieve? Yes. What is new you have come to know about our strategy or leprosy?
Yeah, so myself Chanda, I am from Lepra. Just now Dr. Mandal has said that like it will be like into you'll put from neglected to notifiable disease. That will make a lots of differences in terms of achieving the goals which we have set till 2027. Yeah.
Good.
So thank
good.
you so much. Yeah.
Good. So now if we make it notifiable, I think we can eliminate, we can eradicate leprosy. Wow, thank you very much. So we need not do anything, we'll just make it notifiable. We just make it notifiable. So this is something not new which we have to do. Please remember, this is where we have been failing for the last many years. Had there not been entry of MDT, we know Dapson entered in the arena of treatment in late 20s and it revolutionized the world. We know afterwards how first generation antibiotics entered and they revolutionized. And we know the last entry of clofazimine and what happened after that. And then MDT, and we have reduced. So just making it notifiable, okay, but thank you very much. Something new you have got. Thank you. Next, something new which is out of the box you have heard or thought of. Here.
It's not something new, but a lesson that I'm taking back with me, and that is that Dr. Rashmi just presented some of the best practices across the world. We are very poor in India when it comes to documentation of the best practices, because the several best practices, like we have a lot of SHGs over here who are going about detecting, but unfortunately we have not documented it. And also what I realize over here, that sometimes you're working in silos, and that is something we need to stop if we need to be effective and move towards 2027. So.
Good. So your take is, or your suggestion is, please come. Your suggestion is that if we document SHG's involvement, we are going to eliminate and achieve great success. So how will it help elimination, eradication? I would share, madam, I would share you so many documents in the country we have. We are expert at documenting.
Even for this strategy, we had made a huge reference book, you might not be aware. We had made a huge reference book which could have been a Bible on leprosy. We would give you a copy of that. Please read that.
Sir, actually what one important point was regarding only 10% is learned through training, and I think 70% is learned through field experience.
Perfect.
That is the most important point, I think, which I have learned. So that when during the training program, I think we'll have to keep, I think, 2 or 3 sessions for field level training, so that they go and learn in the field. That is, I think, we'll have to learn.
Yes, please. The point is, I find myself a failure here when we have not been able to, keep 115 people together till the end of the session. That's my failure. Yes, it's my failure. Had I called DDG and discussed, had I not relied upon the team, I would have done it. It's failure of our CLD that we have not been able to keep 115 people here inside this. It's a matter of concern for us. And this is the only lesson which I have learnt. Tell me anything which you think is not there, not practiced across the world. Anything you may say.
Sir.
There's nothing new. We don't have a clean slate to write insofar as leprosy is concerned. Here many experts are there. They know each and everything. The only thing which is missing, the killer instinct. The only thing that is missing is the killer instinct, and the moment we are able to bring back that killer instinct, we would be able to eliminate, we would be able to eradicate. And this is what we are planning to do. Yes, Dr. Saab, please.
Sir, what Dr. Rasmi ma'am and Dr. Lily ma'am both have nicely elaborated the best practices in India as well as in the globally, what actually Dr. Rasmi was telling. Sir, one of the practices what she mentioned, actually that struck me, is the self-examination and the school health. I mean the school survey in the school. Actually, this survey in the school was the long practice, and it was the practice in the long back.
Yes.
And actually, when we were initiated the MDT implementation, at that time the ACT, survey, education and treatment was there. At that time, apart from the house-to-house survey, the school survey was one of the important activity. And from that school survey, a lot of children's, child cases were detected from that survey. And also during that time, the school's children are being sensitized.
Perfect.
Now, the point is that as we have seen the SLAC program now, that was actually being done at the village level. Panchayats are involved, but I think, sir, we should now more focus on the school level, where the children will be the advocate for their families, and they will help the family members for the self-examination, also educate them.
Wonderful.
So one of the, sir, that old concept, what I feel it is still today is realistic.
Yes.
That the self-examination and the school survey in the campaign mode,
very good.
That will, and maybe in the form of a convergence like this. There are a lot of school health programs are going on, and Dr. Nikita madam had developed a lot of IC materials, and those IC materials can be integrated in the school to educate the children and help them to educate their family and ultimately get the self-examination.
Yes, very good, very good. Yes, yes. Anybody else? So. In fact, I wanted to make it a two-way communication. I just wanted to make it a two-way communications. I have nothing to share great with you, nothing to say great which you don't know. The only point is experience of 70s and 30s, as has been mentioned by one of our director of the RLTRI, that at that point of time schools were involved. And in 80s and 19, if you look at the data, we were able to reduce the number significantly. If you recall, in the morning also, involvement of dermatologists would be another challenge. This is going to be another challenge for all of us to think of it and to work on this. We are also going to work on intrasectoral and intersectoral approach. When I talk about intrasectoral, I mean if somebody is examining the case of PKDL, post-collageodermal leishmaniasis, where hypodermal pigmentation could, pose similar symptoms. So all these are going to take place, which perhaps we have captured in our strategy and strategic plan. What is challenge before us is reaching out almost 30 crores family, on which strategy will speak out how we are going to reach out to 30 crores family. I wanted to speak in the morning because rightly mentioned some of you about lepra reactions, antimicrobial resistance. I appreciate all of you, and to my mind, right from the beginning, whatever time I have spent, I have not learned anything new other than the challenges and failures what we have. The best practices what we had in the past, if we need to work on that, I think we can do wonders. But the point is that we have to learn lessons from the past mistakes. Many of you might be aware that we had been struggling with 8 blocks insofar as visceral leishmaniasis was concerned, and within 8 months we have brought down to 1. For the last many months we have been struggling on that, and within 6 to 8 months we have brought down to 1, and we shall be able to eliminate Kala Azar from the country in the next 3 months, though the target is still 2023 end. Here in the similar fashion we need to work here, and the first lesson, as I told, that I would not say that it was failure of CLD or DDG or additional DG. I always take it was my failure that I would have even given more time and asked them. I should have forced them to please come and discuss whether the participants would remain there till the end of session or not. So I'm not going to say that it was someone's responsibility. Being the joint secretary concerned, now in future I should be careful. This happened in one of the programs, and next time I ensured. And that program continued till 6 o'clock in Vigyan Bhavan, and you would find the total strength was 250, and till the evening people were there around 225. So this is how we had ensured through our partners, through WHO, through other institutions, through state governments, through our officers. So this is how we need to do. So these all are, to me as a generalist, I would see that focus should be, all of you are experts, you know that disease prevention would be the focus, which rightly they have talked in this, and they have talked about IEC in a big way. We are going to do that, as has been suggested. You also suggested we shall be approaching the people, reaching out the people, and we need to use not only, the conventional means of IEC, but also all the new technology. So we need to leverage the new technology, maybe social media, something will come to every individual, that have you checked yourself in the regional languages and all. You talked about PEP. Again, it is an important thing, but it should not remain on the paper. This is my concern. This is my concern. It should not remain on the paper. It should be actually practiced. If we have to administer post-exposure prophylaxis, of course it should be after contact tracing and all. So these are a few issues and concerns I wanted to talk to you. Strategy would be different for different states. The states which are endemic, the districts which are endemic, we need to have some 5-pronged strategy. The state which are not endemic, we need to have 4-pronged strategies. All these things need to be worked out, but now we shall be doing that. As I told in the beginning, that we are not going to write on a new slate. Everything is there, everything is written. We are just going to re-emphasize them, pick up the best one, whatever we can do. We would be happy to have your cooperation. India has, ocean of wisdom. We have all the knowledges, but the problem lies in practicing that. Some of us may have, good stock of literature and books and everything, but when it comes to practice, we are not able to practice that. So this is what we have to do. The people who have succeeded, you might see how they have succeeded in international experiences. Nothing new they have done. What you had suggested, they have practiced. Now we have started as intersectoral. We need to write to women and child. We are going to write. We are going to write to Ministry of Sports. We are going to have a health minister conference, health ministers meet, as we did in Kala-Azar, as we did in lymphatic filariasis. We have our own success stories to replicate. Now, all health ministers came and committed at the top level. When secretary held meeting, all additional chief secretaries and chief secretaries, they got committed. When AS and MD addressed, all those principal secretary got committed. When I addressed, all those MDs got committed. Then we had intersectoral meeting. All those joint secretaries of Panchayati Raj, joint secretaries of Women and Child Development, Ministry of Sports, Defense, Railways, all of them got committed. All of them use their available networks, and then the work is moving. This is what we need to do. I believe we need not write a new slate, but to work, give our best to ensure that India achieves. I did not talk about eradication. I still believe that if we are able to achieve elimination as public health problem at district level by 2027, that would be one of the best achievement. We are going to break the chain of transmission. That is possible. Because you are experts, I have no idea whether we would be successful or not, and if that is done, congratulations to them. If that is possible, let us target that. That could be possible. But for me, if we achieve that target, we all should celebrate. India, in the current regime, we all know Honorable Prime Minister, how many hours he works, Honorable Health Minister, they are giving their best. So we need to work, we need to support, we need to come out with the best what we have. And with this, I wish success to the entire team. I would like to congratulate DDG, who really worked hard. And whatever we see today, it would have not been feasible, but it is because of his hard work. Something messed up, which all failures I would own, and I would pass all success to my team, because this is more important. The team has to further lead this mission. So thank you very much.
Thank you, Shri Rajiv Vanji Sir, Joint Secretary, Leprosy, Ministry of Health and Family Welfare, Government of India, for enlightening us, for your motivating words. And with this, ladies and gentlemen, we conclude today's event. But before that, I would invite Dr. Anjali Chauhan to kindly come onto the stage, please, and felicitate our respected Joint Secretary, sir, by presenting a memento to him. I request Dr. Vijay Dhange to please come onto the stage and felicitate Dr. Lily Gangmai by presenting a memento to her as a token of thanks. Thank you. So thank you, ladies and gentlemen, all dignitaries and participants, for sparing your precious time and gracing the occasion. Thank you so very much. So with this we conclude, and please join us for tea. Thank you so much. Thank you once again. Namaskar. I'm leaving because I have another meeting. Tomorrow President Ma'am is coming in.